A very good evening to one and all. I am Dr. Sanish, and this is WebinarCAMPUS, classes in acute medicine with precision, understanding, and simplicity. And this session, we are doing it in association with my YouTube channel, Anesthesia Tools. Today, we are having a focus session, and the specialty of today's webinar is this is going to be a multidisciplinary discussion. Our topic today, or the focus today, will be on perioperative ECG basics and more. Today onwards, we are issuing e-certificate of attendance to all the attendees. Only thing is you need to fill in a feedback form wherein you will be entering the name as it should appear here in the certificate, and the email address should be properly typed in. So because we will be sending this certificate, e-certificate on PDF format right into your mailbox. Coming back to today's topic, today's focus session is perioperative ECG, basics and more. And I'm happy to introduce my panelists for the day who are enthusiastic academicians. Dr. Shifas Babu M, who is a consultant interventional cardiologist working in Anandaburi Hospital and GG Hospital, Trivandrum, Kerala. Dr. Shifas, your opening remarks, please.
Yeah, thank you, Sanish. First of all, let me thank Dr. Sanish for giving me this opportunity. Actually, this is the first time I am giving a talk to a anesthesia group. And I really appreciate Dr. Sanish for his pain and effort to maintain this sort of academic activities. Thank you, Sanish.
Dr. Shifas, not only anesthesia, I think I can recognize many of the participants are from the other acute medicine subspecialties also, critical care.
Yeah, correct.
Also. So we usually, our webinar campus audience is a mixed audience, but I think since we have termed it perioperative, we'll speak more on the light of anesthesia side when it comes to interpreting ECG. Next, I'm proud to introduce a senior person, head of the Department of Government Medical College, Mysore, Dr. HG Manjunath, who had been with us as faculty before as well. And he's a seasoned examiner, and I believe all the participants will enjoy or benefit from his input during the discussion. Welcome, sir. Sir, your opening remarks.
Yeah, thank you, Dr. Sanish. So indeed, it's my pleasure to participate in your webinar campus. I think I have done 2 or 3 sessions during this past lockdown period. Now it is you introduced. You're doing very well in your webinar campus. This thing, the topics are good, definitely good, and it is helpful for the postgraduates as well as the practicing anesthesiologists elsewhere. So thing is, today's webinar campus where you are having ECG, it is definitely one of the minimum monitoring standards which is introduced by ISA in India, and it is very useful for all the patients who are undergoing general anesthesia, and it is a mandatory nowadays. So we have to have a ECG, and you should have a basic knowledge of ECG, and you should identify the arrhythmias which are happening in the intraoperatively, and you have to treat it. It is it is very important. And as anesthesiologist, I think we need to know the basics as well as the identifying the dysarrhythmias. I definitely agree with you, and hats off to you for choosing this topic. And what I will do is from our department. So greetings from Department of Anesthesiology, Mysore Medical College, and I have got some the scenarios, and we're going to ask questions for our postgraduates or any participants. So we're going to modify it. It's an interactive session more than lecture. It's an interactive session, and I'll happy that we're going to have another 1 or 2 hours. So we'll be having interactive sessions. Thank you, Sanish, Dr. Sanish.
Okay, thank you. I actually have revealed the second point in our highlight in our session today. Today we are having a consultant from a different specialty. Also, we are planning to make this as an interactive session with postgraduates participation as well. Actually, last week we have done some pre-tests in our Telegram group, and there was a good response identifying the ECG rhythms and some points pertaining to the ECG identification and subsequent management. They were a good response, and I'm not going into the details, but I'm happy that almost 75% plus were hitting the right answer. And we'll also come to this OSCE questions, which were asked in the last national board exams. And I think it's time to go over to Dr. Shifas for his presentation on how to approach a perioperative electrocardiogram or ECG. Over to Dr. Shifas.
Okay. Thank you, Sunny. Shall I share my screen?
Yeah, please. I request all the other participants to keep muted. During interactive session, we'll enable your microphone.
So, is it visible?
Yeah, you can go to the slide share.
Yeah, I'm sharing.
No, slideshow.
Yes. Yeah. Is it okay?
Yeah, fine. You can go ahead.
Okay, so thank you, Sanish. Once again, good evening to everyone. So I'll be talking some basics about how to read ECG and how to systematically read ECG and how to diagnose abnormalities. So first of all, what is the indication for an ECG in a surgical patient or a patient posted for surgery? If you are looking into the guidelines, where it is a European Society of Cardiology guidelines or Anesthesia Society guidelines, ECG is indicated for intermediate or high risk surgery or those with risk factors or those those are above the age of 65 years. Routine perioperative ECG is not recommended for patients who have no risk factors and are scheduled for low risk surgery. But if you are asking me whether ECG is indicated for all patients, I would say yes. We have to have an ECG for all patients. Because actually ECG is a simple investigation. It's cheap and it's very easily available. You don't need to ship the patient to anywhere. It's usually available in bedside. And you know, which is electrocardiogram, we can recognize many cardiac problems. And more than that, we can recognize many non-cardiac problems also with the ECG. And we all know that there is nothing like a zero risk procedure, zero risk surgery. Any patient can have anything at any time. Even a vasovagal phenomena can happen to anyone, even with a simple procedure. So many times something happened to a patient during a procedure or during surgery, and the first investigation usually we are asking will be a ECG. And many times a baseline ECG, if there is if therefore a comparison, it will be very handy in such situation, because certain changes, maybe some ASC changes or some TO changes will be there in the perioperative ECG also, so that we can make a decision fast. So I will show you 2-3 ECGs. It's not for a diagnosis and all, for just for some interesting aspect, because of some interesting aspects. And you know, now it is COVID era, there are a lot of tele consultations and WhatsApp consultations and all. And look at this ECG. This ECG actually, this is a normal ECG only, but I'm showing this ECG because this ECG, this actually looks very beautiful. There is no artifacts. The baselines are very regular. So when you see this ECG at a distance or in other ways also, we can say that that patient is actually not in distress. Patient is actually relatively stable and not in distress at all. In contrast with this ECG, many might have seen a lot of ST changes and rhythm abnormalities, but the thing is, this ECG shows a lot of artifacts, a lot of baseline artifacts. And all. So the moment you are seeing this ECG, we know that the patient is not stable at all. Patient is in distress. It may be a hypotension, it may be a pulmonary edema, or it may be in hypoxia, or he will be in severe pain. So whatever the patient is now will be in distress. By seeing this ECG itself, we can solve it without reading anything. And I will show another interesting aspect. This is one ECG, and otherwise benign looking ECG. But if you are looking carefully, you can see that certain leads, that is lead 1 AVR lead, showing some baseline changes, some baseline artifacts, noises, but the other leads all very nicely taken. So what is happening here? Here, see, the lead 1 AVR, this means that these leads are related to right upper limb. So maybe the patient is having some tremor involved in the right upper limb. So that is why that particular lead showing some basal abnormalities and other leads are okay. So this is basically because a unilateral asymmetric tremor, so maybe a patient is having a Parkinson's, and that is why the ECG is like that. So if you are looking carefully into the ECG, you can diagnose many things at the outset itself. So this is the beauty of ECG. So with this remarks, I will go to the topics in proper. So in the next few slides, I am just trying to describe how to read an ECG in a systematic way. So before that, we have to understand certain things. So in our heart, we have conduction system, and the pacemaker, all impulses coming from the side SA node. It is located in the right atrial tree wall near to this superior vena cava. Then we have an AV node. Then we have bundle of His. Then bundle branches. We have right bundle branch and left bundle branch. And left bundle branch have two divisions, that is left antedivision and left posterior division. So the impulses in patients' heartbeats, the impulses starts in this SA node. Then first it spreads in the atria and repulses the atria. So at that time we'll get a P wave. Then through the AV node and through the bundle branches and the Purkinje fibers reaches the myocardium and produces ventricular depolarization. So at that time we'll get a QRS complexes. Then the myocardium go to repolarization. So it will produce a T wave. So basically the ECG is having a P wave, a QRS complex. So P wave indicates atrial depolarization, QRS indicates ventricular depolarization, then we have T wave that indicates ventricular repolarization. So where is the atrial repolarization? Atrial repolarization is within the QRS complex. It is buried, so it is not visible in the surface ECG. So in the ECG we have some intervals also, that is PR interval, then QT interval, ST segment and PR segment. So all these things will come later. So generally we are taking a 12 lead ECG. What does it mean? A 12 lead ECG means we have 6 limb leads as well as 6 chest leads. Limb leads are representing the heart in the frontal plane. So we have lead 1, lead 2, lead 3, AVR, and augmented leads like AVL, AVR, and AVF. And chest leads like V1, V2, V3, V4, V6 generally. And sometimes we'll order for a 14 lead ECG, especially V3 or V4, especially in a patient, if you are suspecting a right ventricular infarction in an inferior wall of patients, we usually advise for a V3 or V4. And sometimes if you are suspecting a posterior infarction or ischemia, we usually order for a V7, V8, V9. So why we need this sort of leads? This because each lead represents the heart, different walls of the heart. For example, lead 1, AVL, V5, V6, all these leads represents the lateral wall of the heart. So any changes or ischemia will be visible in this lateral wall will be visible in these areas, these leads. And V1 to V4, maybe it's representing the anterior wall of the heart. So anterior wall, for example, anterior wall infarction, ST elevation will be in these leads. And the 2, 3 AVF, which represents the inferior wall of the inferior area of the heart. So inferior wall, the ST elevation will be in the 2, 3 AVF. So because 2, 3 AVF indicates the represent the inferior wall. So and each leads looking at the heart in a particular angle. For example, the AVL looking at the -30, lead 1 in 0 degree, lead 2 in 60 degree, AVF in 90 degree, lead 3 in 120 degree, and AVR is 150 degree. And we have to understand one more thing. We know that heart myocardial conduction is an electrical activity, and there is an electrical activation from so the activation will be in one direction. So usually the impulse starts in the SA node. So SA node is situated in the right atrium near to the superior vena cava. So impulse starts from there, and it is going left as well as to down. So whenever a depolarization is moving towards a lead, the lead will show a positive deflection. Whenever the depolarization is moving away from the lead will show a negative deflection. So whenever the depolarization is perpendicular to a particular lead, it will show a biphasic wave in that particular lead, or it will be a straight line. So whenever the depolarization is towards the lead, it will show a positive deflection. whenever the depolarization is away from the lead, it will show a negative depolarization. This idea should be there to read the ECG, because I will tell you why. So I told you the repolarization is starting from the SI node. So it is basically, if you are looking into the heart, it is situated in the right upper quadrant. So mainly the repolarization will be from the right upper quadrant towards left and down. So if you are looking in the, you can see that the AVR is our right upper quadrant. So the depolarization is moving away from the AVR. So in a usual patient, in a normal ECG, the P and QRS complex will be negative in the AVR. Similarly, it will be positive in the lead 2 and especially in the 1 and AVF also. So this is a basic principle of the axis, and as well as the basic principle of the positive and negative reflection in the ECG. It is all based on the where is the depolarization is moving. So this is important to understand this this principle. So look at this ECG here. You can see that in the AVR, the P wave is negative, the QRS is also negative. That means that the depolarization of the atria as well as the ventricle is moving away from the AVR. And look at the lead 2, both will be positive. So in a normal ECG, in a normal sinus rhythm ECG, generally the AVR will be showing negative P wave and negative QRS complex, and lead 2 and lead 1, AVF will be showing positive P wave and positive. This is actually very simple, and there will be some changes. This we have to identify, because the most common mistake while taking an ECG is reverse of the limb leads. So whenever you get an ECG, first you look at the AVR, whether that P wave is negative and QRS is negative. If the AVR is showing a positive P wave and positive QRS complex, immediately check whether we have taken the ECG correctly, because most probably in ICUs and in emergency setup, this is the most common mistake. The right and left leads will be misplaced. So next we have to identify understand what is the ECG paper is. So the ECG paper, usually it will be moving at a constant speed of 25 millimeter per second. And ECG paper, we have a small square. The smallest square means it is actually 0.04 second, that's 40 milliseconds. Then we have a big square that contains around 5 small squares. So 5 small squares means 5 into 40, that is 200 milliseconds. So to get 1 second ECG, we should have a 5 big squares. So because each small, one big square have 5 small squares, each small square is 40 milliseconds. So 1 big square is 5 small square, that is 200 milliseconds. 1 second is 1000 milliseconds. So we have to get 5 big squares to get 1 second. This is also important. Why that I will tell you in the coming slides. So coming to ECG interpretation in a systematic way. So before interpreting an ECG or X-ray, whatever investigation we are getting, we have to identify the patient name, date, time, and in case of ECG, we have to see whether it is a properly taken ECG. And we also should get a proper history, because we know that in clinical medicine, the investigations have no value if it is not correlated with the patient's history or patient's clinical examination. So we should get a proper history, then only evaluate the and interpret the ECG. So in ECG, we have, in a systematic way, we have to see many things. That is standardization, rate, rhythm, P wave, PR segment, QRS, ST segment, T wave, QT, U wave, etc. So what is standardization? In normal standardization, you might have seen this sort of, this particular image in the either end of the ECG. So what does it indicate? It indicates that 1 millivolt is, about 10 millimeter of the TC strip indicates 1 millivolt in amplitude, and paper speed is 25 millimeter per second. And in this B, it indicates it is 50 millimeter per second. In C, it indicates that amplitude is actually it is half. The 1 millivolt is 5 millivolt. Actually, look at this ECG. This is actually normal standardization, and that is a 10 millimeter is showing 1 millivolt. And see, this is actually double standardization. You can see in the right upper corner, it is 20 millimeter per millivolt. So always look at the standardization, because otherwise, if you are simply looking at this ECG, will recognize, will identify LVH in this patient. That is because we are seeing this ECG in a double standardization. And another thing is, see, this is half standardization. And you have to check the standardization. What is important is half standardization, because if suppose the patient is, we have the ECG with a half standardization, we may miss a mild ST depressions or ST elevation in such situation. Oh. And this is another important thing, because you have to check at the paper speed also. Here the paper is the same previous ECG. I took it in the. This is 25 millimeter per second, and this is actually it is 50 millimeter per second. If you are not looking into that speed level, you will identify a bundle batch block, as well as a bradycardia in this patient. So you should, before starting the interpretation, you should look at the standardization. It is very, very important. So now coming to rhythm. So rhythm, during a surgery or preoperative period or during in ICU, we all happy with that when the patient is having a sinus rhythm. So how to identify sinus rhythm? You know that I told you, if the impulse is coming from the sinus node, we will get a positive deflection in the lead loop, or positive PVS in the lead loop, and AVF also, positive deflection, and AVF will be showing a negative deflection. And if it is a sinus rhythm, each paving will be followed by a QRS complex. So this is a sinus rhythm. Is it a normal sinus rhythm? This is a normal sinus rhythm, because the rate is also in the normal rate, it's around 88 per minute. So it is a normal sinus rhythm ECG. And look at this ECG. Here you can see the P wave is inverted in the lead 2, lead 3, and the AVF. So that means that when looking from the 2-3 AVF, the depolarization of the atria is going away from 2-3 AVF. That is, so the depolarization starts in the lower part of the atria, not in the sinus node. That is why this depolarization of the atria, when looking from the 2-3 AVF, it is negative, because the depolarization is going away from the 2-3 AVF. So it is actually not a sinus rhythm. It is actually a low atrial rhythm. This is not a sinus rhythm. It's a low atrial rhythm. Many times this is a normal phenomenon. It's a benign phenomena. But whenever you get this sort of things, you have to ask the patient whether the patient is having any syncope or pre-syncope or palpitation, and so that to identify whether the patient is having a sinus node dysfunction or something like that. But many times this is a normal phenomenon. So there are many other abnormals that we will discuss in the interactive session. So then coming to rate, how do you recognize rate? That it is basically the most easiest method is the 300 divided by number of B squares. So, I think this all everybody knows. If it is 6 squares, the 300 by 6 means 50. If it is 5 squares, 300 by 5 it is 60. So it's actually, and in many times in modern ECG machines, the rate will be written in the automatically typed in the ECG string. And here actually there are two big squares between two QRS complexes. So the rate will be 300 by 2. So it is 150. And here the P waves are up in the lead 2, 3, and AV. So it is a sinus rhythm, and each P wave is followed by a QRS. So it is a sinus tachycardia. So here it is a sinus tachycardia at a rate of 150 in this ECG. And what is happening here? Here also the P wave is normal, looks like a sinus P wave only, and it is and each P wave is followed by a QRS complex, but the rate is low. Rate is around 42. It's around 7 squares, so it's around 40, 42. So it is a sinus bradycardia. So this is how, so this 300 divided by the big squares is applicable when the patient's rhythm is regular. Suppose you have irregular rhythm. So for everybody understand that this is a atrial fibrillation ECG, and you can have a very nice fibrillatory wave in the V1. So it is a atrial fibrillation. So in a atrial fibrillation, which QRS complex you will take? So in a atrial fibrillation, we cannot apply this 300 by a number of the squares rule. So what we have to do, we have to see. I already told you that. Actually 5 big squares constitute 1 second. So you just count the 6 seconds at least. So 2, 3, 4, 5, 6. So 6 seconds actually how many combos we have? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 combos we have in 6 seconds. 10 complex we have in 6 seconds. So in 6 seconds, 10 complex. So in 1 minute, how many we have? It is 100. So it is a atrial fibrillation with a ventricular rate of around 100. That is how we can calculate the rate in the atrial fibrillation ECG. So now coming to P wave. So then, so we look at this standardization, then look at the rhythm, then look at the rate, then look at the P wave. So normal P wave. So normal P wave will be smooth in quantum, monophasic in lead 2, and biphasic in V1. And the axis will be, I told you, so it is the exact axis. It is difficult to estimate, but just look at the lead 2 and AV. If it is positive, it will be normal. Then it will be upright in 1 and 2 and inverted in AV, already we discussed. And the normal duration of PO will be 120 milliseconds. That is 3 small squares. Each small square is 40 milliseconds. So normal duration will be 3 small squares. And normal height also is 2.5. That is also roughly 2.5 or 3 small. So whenever you get an P wave, the duration is more than 3 squares or height more than 3 squares, it is abnormal. So what are abnormalities? Basically, it is P wave is atrial depolarization. So any abnormalities in P wave indicates the atrial enlargement. So in lead to suppose if the height is more than 2.5, that indicates right atrial enlargement. If the width is more than 3 squares, that indicates left atrial enlargement. In V1, actually, we'll get a biphasic. So in biphasic P wave, so the most important thing is that that second part, that the negative deflection, that part is the most important. That's slow. If the slope is more than 40 milliseconds, that indicates left atrial enlargement, and it is otherwise known as Morris index. So, what is the importance of left atrial enlargement? So, most commonly we will see left atrial enlargement in patients with hypertension. But in a surgical patients, we have to identify many times the P mitral will be the only first sign of the patient with mitral stenosis. We have to identify when we see this left atrial enlargement like this P mitral, we should look for the mitral stenosis, because you know if the mitral stenosis is if significant mitral stenosis go through a surgery and the patient is developing some and if we are getting some fluid and the patient develop pulmonary edema. So it is very important to identify this atrial enlargements. So right enlargement, similarly, we will get a peak the height will be more than 2.5 squares. So when
Shifas,
yeah,
many people are asking to go slow. Time is okay with us.
Time is okay
because these are very basic concepts.
Okay, okay. I thought because the time, that's why I'm rushing. Okay,
that's
so
okay, that's okay.
Yeah, okay, okay. So yeah, okay. Then we'll come back to. So so look at the P wave. So basically, I told you the P wave height will be less than 2.5 or 3 small squares. P wave width also will be less than 3 small squares. So the P wave will be readily visible, nicely visible in lead 2 and V1. So look at the lead 2 and V1 first. So in lead 2. Usually P wave will be monophasic and V1 it will be biphasic. So whenever in the lead 2, the P wave, suppose the P wave height is big, more than 2.5, 3 small squares, that indicates that the patient will be having a right atrial enlargement. So most common conditions associated with right atrial enlargement will be a pulmonary hypertension. That in surgical point of view also, one of the most important thing we have to identify is the pulmonary hypertension. So that is very important. Similarly, if the P wave duration is more than 120 milliseconds and with a notch in between, that it is otherwise known as P mitral. So that indicates left atrial enlargement. Similarly, in V1 also, that biphasic part, the second half of the P wave will be, you have to look at that slope. If that slope is big, that duration of the slope is more than 40 millis, that indicates left atrial enlargement. That is otherwise known as the Morris index. And in right atrial enlargement, what happens? That depth is high. The depth will be more, but the slope will be very steep. So it is otherwise known as pseudo left atrial part. But that indicates actually right atrial enlargement. So this is how you identify left atrial enlargement in the ECG. So what is it's important, because the left atrial enlargement, it indicates the most common cause for left atrial enlargement in common scenario is hypertension. The other conditions are mitral stenosis, mitral dilatation, and some patients with the aortic stenosis and dilatation, and sometimes left atrial myxoma. Sometimes left atrial myxoma will be this will be the only finding in the ECG. And similarly, right atrial enlargement, I told you the height of the PV will be high, and the V1 will be showing a steep down negative deflection in the V1. It is otherwise known as pseudo left atrial pattern. So what are the conditions we have to suspect when you see this sort of ECG? This is most importantly pulmonary hypertension, then co-pulmonal, then tricuspid. Similarly, microstenosis will produce left atrial enlargement. Similarly, tricuspid will produce right atrial enlargement. Then pulmonary stenosis, TOF, Epstein anomaly. Epstein anomaly, actually it is known as Himalayan BBS. The P will be as tall as QRS complexes. So what is important of Epstein anomaly? Because Epstein anomaly there will be associated with multiple accessory pathways, and the patient may develop supraventricular tachycardia during any procedure. So that is important with this identifying this. This is in the ECG. So now coming to PR interval. So what is PR interval? It is the duration from duration. It is the interval from the beginning of P wave to beginning of the QRS. So in normal PR interval will be 120 to 200 milliseconds. That is 3 to 5 small squares. So the PR interval will be at least in the within that big square. Normal PR interval will be within that big square. That is 120 to 200 milliseconds. But theoretically, it is more than 200 milliseconds is first degree heart block. PR interval is prolonged, but up to 240 milliseconds is okay, because in many normal persons, some mild increase in the PR interval, some 220 to 30 milliseconds is seen. But more than 240 anyway, we have to be careful. But by definition, normal PR interval is 120 to 200 milliseconds. That is 3 to 5 months. So what are the abnormalities in the PR interval? It can be short, it can be long, it can be varied. So this is in this ECG. Look at the lead 2 or AVF. The beginning of P wave to beginning of QRS is around 4 or 5. So I am 4 small square. That is around 4 into 40 means 160 milliseconds. So in this ECG, the PR segment, this PR interval is normal. But look at this ECG. Here, this ECG will go in a proper way. Look at the standardization. The standardization is okay, and we have P wave. The P wave is positive and lead to AVF and all. So it is a sinus P wave only. But the PR interval and the P wave duration and height is also is okay. So the atrial enlargement is also not there. But the PR interval, if you are looking at the PR interval, it is around 260 milliseconds. If you look at the it is anyway around one big square, that is more than 200. And again some 4 squares, so around 8 into 40, so around 320 millisecond PR interval. So this is definitely a first degree heart block. So the PR interval is definitely prolonged. This is a first degree. So what is importance? So whenever there is a prolonged PR interval, we should be cautious in giving anything which block the AV node, like a beta blocker or a digoxin, or such AV node blocking drugs, we should be cautious, because when you give a AV node blocking drugs in this sort of situation, patient will, this first degree heart block will develop into a second degree or third degree complete heart block. So this is the importance of the PR interval. So what is happening in this ECG? Here also look at the P wave. P wave is separate, so it is a sinus P wave only. But here the PR interval is very short. That is actually the PR segment is not at all there. So PR is very short. It is less than 120 millisecond PR. So what is actually a typical ECG of a pre-excitation, or otherwise we will call it as WPW syndrome. So it is a pre-excitation. So what is important? Whenever you get this sort of short PR interval in the WPW syndrome, we should be cautious, because patient can develop an SVT at any time. And in this sort of patients, if the patient is developing an atrial fibrillation, it is more dangerous. So whenever you see this sort of short PR interval, be cautious during perioperative period. So now coming to QRS complex. So QRS complex, it represents the ventricular depolarization. So what are things we have to look in the QRS complex? We have to look first duration, then axis, then morphology, then amplitude. So so in a subject older than 16 years of age, any QRS duration more than 110 milliseconds is regarded as abnormal, because a normal QRS, so 110, or roughly we can take here also 3 small squares. So total duration of this QRS complex will be less than 3 small squares. 3 small squares means 120 milliseconds. So roughly it should be less than 3 small squares. So whenever the QRS complex is more than 3 small squares, it is wide QRS complex. Then axis, I already mentioned the importance of that principle. Whenever the depolarization is towards the normal axis, we'll get a positive deflection in the corresponding leads. So in a normal axis patient, usually the lead 2 it will be positive, lead 1 and AVF also will be positive, because that electrical axis is generally moving from right upper quadrant towards the left hand down. So the lead 1 will be this side, lead 2 will be left hand down, then AVF will be at 90 degrees. So usually in a normal axis patient, lead 1, lead 2 and AVF will be positive. So suppose in that one, okay, I'll come to that with a picture. So this is the ECG. So in this ECG, you check the QRS complexes. QRS complex, actually that complex is just 2 small squares. So the QRS duration is only 80 milliseconds. So this is a normal duration of QRS complex. And I will show you another example. See, look at this ECG. In this ECG, the QRS complex is more than 3 squares. So it is definitely a wide QRS complex. But whenever you get this sort of ECG, always check the paper speed. Here the paper speed is 25 millimeter per second. I told you, because if the paper speed is 50 millimeter per second, we will misdiagnose it as a wide QRS. So here the paper speed is 25 millimeter per second, but the QRS duration is more than 3 small squares. So it is definitely a wide QRS complex. So what is the diagnosis in this ECG? It is a left bundle branch block. Why it is left bundle branch block? Here it is basically it's because of a positive complex in the lead 1. And in bundle branch block, easiest way to identify left and right is look at the V1. If the V1 is showing a predominantly negative complex, it is left bundle branch block. If the V1 is showing a predominantly positive deflection, it's a right bundle branch block. So in bundle branch block, basically the QRS will be duration will be more than 110 milliseconds or roughly 120 milliseconds. And look at the V1. If it is predominantly down, it is left bundle branch block. If it is predominantly up, it is a right bundle branch block. I will show you that. So look at this ECG here. That QRS is wide as well as it is more positive in the V1. So it is a right bundle branch block. So usually the right bundle branch block is benign when compared to left bundle branch block. Whenever you get, actually both bundle branch block can be normal in many persons, but in whenever you get a left bundle branch block, and if you have an X-ray also, suppose the X-ray is also showing some cardiomegaly and you have a patient with a left bundle branch block, definitely you should order for an echo, because usually the dilated cardiomyopathy patient will be having left bundle branch block pattern. So whenever you get a cardiomegaly with a left bundle branch block, always ask for a echo because there will be a undiagnosed dilated cardiomyopathy in that patient. And right bundle branch block in the other way, it will be, usually it is benign, it will be benign, but sometimes the atrial septal defect patient will be having right bundle branch block pattern. Sometimes a PH patient will be having right bundle branch block pattern. So whenever you get this thing, ask for a cardiology opinion. And this is actually a very important ECG in a perioperative point of view, because here also the QRS is wide, so and it's a right bundle branch block pattern. But here the thing is, you have a pathological QR pattern. So what does it indicate? Whenever you get a QR pattern, QRBB, we will otherwise call it as QRBB. This sort of ECG, this indicates an old, very proximal LAD occlusion, old anterior MA. And the patient will be having very proximal LAD occlusion because the bundle branch is getting supply from the proximal part of the LAD. So whenever you have an ECG, when a patient with the anterior MA with the RBBB, or whenever you get a ECG like this, Q with an anterior MA, that indicates that the patient might have an XNC anterior MA. The patient will be, the LV function will be abnormal and so this is actually really a pathological ECG. So this is another ECG. Here also the QRS complex is wide, but here is it a sinus rhythm? It is not a sinus rhythm because you can see a pacing spike. There's a sharp spike before each QRS complex. It's a spacing. So it is a ventricular paced ECG. So paced ECG also will show a wide complex because the rhythm is arising from the ventricle. But in short, any rhythm arising from above the bundle of his will produce a narrow complex. Any rhythm coming or originating from below the bundle of his will have a wide complex. So what are the complex? What are the results for a wide QRS complex? It is, I told you, it is a left bundle branch and right bundle branch block, then WPW ECG, then ventricular paced rhythm. We have seen one. Then ventricular S-type rhythm in complete heart block. So it is important because if the patient is having a complete heart block and you have a wide complex, that is, it is more dangerous than a complete heart block with a narrow complex. Because when you have a narrow complex escape in the complete heart block, it indicates that the escape is from the suprahysian. So it is more stable. When you have a wide complex escape rhythm in complete heart block, it is not that stable. So as the duration of the complexes widens, the rhythm will be less and less stable. So that is the importance of a duration of the QRS complex in a complete heart block. Then we all know the ventricular tachycardia is a wide complex tachycardia. Then I already mentioned that if the patient is, if the ECG is taken at a higher paper speed, you will get a wide complex. So this ECG, is it a sinus rhythm? Anybody to volunteer in this ECG?
I think if PGs are ready to volunteer, you can volunteer. We'll
Just read this ECG. Is it a sinus rhythm ECG or is it something else?
Dr. Nisha, you can unmute. Yeah, you can introduce yourself and take the question. Can't hear.
Yeah, anyway, we'll be discussing. Yeah. So here also we go systematically. So it is the standardization. Actually, standardization has written down also. It is 25 millimeter per second and 10 millimeter per volt. So the standardization is okay. And is there any P wave here? We cannot see any definite sinus P wave here. So it is definitely, it is not a sinus rhythm. And there is QRS complex is narrow. So and it is actually how much is the rate? So there are two big squares between two QRS complexes. So 300 by 2 means 150. So we have a tachycardia at a, we have a narrow complex regular tachycardia at a rate of 150 per minute. So what will be the diagnosis here? So we can say, so for practical purpose, we can call it as a SVT. Okay, so but SVT supraventricular tachycardia means it is a general. It's a supraventricular tachycardia can be, it can be AVRT, it can be AVNRT, it can be atrial tachycardia, anything. It is all supraventricular. So supraventricular. So by all practical purpose, we can call it as a SVT. So what about this one? Here actually the QRS complex is wide, and here also tachycardia is around 150, 170, right? So it's a wide complex regular tachycardia. It is VT unless proved otherwise. It is VT unless proved otherwise. So, okay. So now coming to the QRS axis, I told you. So the normal QRS, the heart depolarization will be left and down. So when we look from the AVF and lead 1 or lead 2, the complexes will be, the QRS complexes will be positive. So when the when the normal depolarization is towards this quadrant, the lead 1 and AVF and lead 2 will be showing the positive. So just look at the lead 1 and the AVF. If both these leads showing a positive complex, that means that patient electrical axis, the QRS axis is normal. Suppose the AV lead 1 is positive, but AVF is negative. What does it mean? When look from the AVF, the QRS the depolarization is going away from the AVF. So that means that the patient is having a negative left axis deviation. Similarly, if the lead 1 is showing negative and the AVF is positive, then what does it mean? When we look from the lead 1, the depolarization is going away from lead 1. So we have a right axis deviation. So this is the simplest way where we can actually precisely tell how much this axis is, but that is a little more complex. But this is the most easiest way to identify normal axis and right or left. So if both AVF and lead 1 is positive, it is normal axis. Suppose lead 1 is positive, AVF is negative, it is left axis deviation. Suppose AVF is positive, lead 1 is negative, that is a right axis deviation. So what is the importance of this axis deviation? Generally, if you are looking into this thing, it is not much importance to do that. But it is important, certain situations it is important. If you are correctly identifying the change in the axis in the ECG, and suppose we have a ECG to compare also, it is useful in many situations. For example, suppose a patient is having a LBBP and the patient is having a tachycardia. Suppose the patient is having an LBBP and suppose the patient is having a tachycardia. The pre-op ECG is showing LBBP. Post-operatively, patient is developing a tachycardia at a rate of 150 per minute. And if you are looking into the axis, suppose the axis of this tachycardia is entirely different, then it will be a VT more than a sinus tachycardia in that particular patient. Because if the patient is already having LBP and patient is having a sinus tachycardia, the axis will be normal only. It will be white complex regular tachycardia only. We will misinterpret it as a ventricular tachycardia. Suppose that axis is different from the baseline ECG and the tachycardia ECG, we can show that okay, this is not a sinus tachycardia, this is a ventricular tachycardia. That is one useful thing with the axis determination. And another thing, suppose a patient we have an ECG, there is an axis shift. Suppose a right axis shift in a patient in the post-operative period, and patient develops some hypotension or some dyspnea. And we usually, and we get a right axis shift in that particular ECG. It may be a pulmonary embolism, and because of the right ventricular strain, the axis shifted towards the right. So this is the importance of this. This is some useful useful scenario where the axis is useful in clinical decision. So this we have already discussed. And now coming to the QRS amplitude. So we discussed about the QRS duration, we discussed about the QRS axis, now coming to the QRS amplitude. Here also, as I told you, you have to look at the standardization. Here the standardization is okay. So in this ECG standardization, okay. So look at the QRS component. This amplitude is very high. When the QRS amplitude is high, what does it mean? It indicates ventricular enlargement. So how to identify ventricular enlargement? So in this ECG, what are the criteria for left ventricular enlargement? It is, at least we should know two criteria. The most easiest method is to identify so-called line criteria, that is S in V1 plus R in V5. If it is more than 35, that indicates LVH. And other criteria also there. It is coronal voltage criteria, that is S in V3 plus R in VABL. That you go through later. It is available in all textbook. Why it is important? Because in many times, sometimes one criteria will not be there, the other criteria will be there to identify the LVH. And one more thing we have to understand. The echocardiographic correlation of the LVH criteria will be around 50 to 60% only. So all patients, even if you have a LVH in the ECG, may not be having a LVH in the echocardiogram. So look at this ECG in S1 in the V1. V1S plus V2, V6R. If you count the squares, 5, 10, 15, 20 here. So here 20, here 5, 10, 15, 20, 25. So 40, more than 45 already it is there. So S1 in S in V1 plus R in V6 more than 45 in this patient. So the patient is definitely having an LVH. So this is the so-called line criteria. Another criteria I already told, it is coronal voltage criteria. That is in S in ABL plus R in ABL plus S in V3. If it is more than 28 in male and 20 in female, that is also indicates a right left ventricular hypertrophy. So what is the importance of identifying this left ventricular hypertrophy in the preoperative ECG? Because if we have the most common cause will be hypertensive heart disease. Suppose a patient is having normal pressure and we get this much left ventricular hypertrophy, then we have to look for the other causes. The most important thing, especially in the perioperative period or in a pre-operative period, it will be a significant aortic valve stenosis, or it will be a hypertrophic or hypertrophic obstructive cardiomyopathy, or it will be a dilated cardiomyopathy. These things we should not miss pre-operatively, because you all know that the implications of these things in the operative period. So that is the importance of identifying the LVH in the preoperative ECG. Similarly, RVH also we have to identify. Here, what are the RVH criteria? You can see, you can look for the right axis deviation, and you can look for the dominant R wave in V1, because V1, if it is more than 7 millimeter, or R by S ratio more than V, because in normal person, the R wave in the V1 will be small and S wave will be very small, big. So suppose you are getting a big R wave in the V1 and a small S wave in the small S wave in V1, then that indicates a right ventricular hypertrophy, provided if there is no bundle branch blockage. Here any bundle branch blockage is there. Here there is no bundle branch blockage. Why? Because the QRS duration is normal. Here the QRS duration is less than 1 millisecond only, so there is no bundle branch block. But the R wave height is more than 7, or the R by S ratio is more in V1, so there it indicates a right ventricular hypertrophy. So when you get a right ventricular hypertrophy in a preoperative ECG, what does it indicate? You have to look for a pulmonary hypertension. Or it can be an advanced mitral stenosis patient. Then because mitral stenosis patient will develop pulmonary hypertension and right ventricular hypertrophy. Then it can be a pulmonary embolism patient will show this sort of ECG. Then chronic lung disease, chronic copper. Then tetralogy of Fallot. You know that one of the features of tetralogy of Fallot is right ventricular hypertrophy. Then pulmonary stenosis. So these things should go through our mind whenever you get a ECG like this. So now coming to ST segment, that is one of the most important area of the ECG. So the ST segment can be isoelectric, which can show ST, or it can show elevation, or it can show depression. So look at this ECG here also. It is actually sinus rhythm ECG. We already discussed these things. Sinus rhythm ECG, P wave is normal, PR segment is normal, QRS is normal, QRS axis is normal, and here the ST segment, here actually ST segment is isoelectric. So here that ST segment, there is not much significant ST segment deviation. But look at this ECG. Here what we are seeing here. Look at here also we go to systematically. See the standardization is okay. What about whether the rhythm is sinus? Yes, the rhythm is sinus because the P wave in lead 2 is okay. AVF is positive, and each P wave is followed by a QRS complex, and PR segment is normal. PR interval is normal. QRS with duration also normal. What about QRS axis? Lead 1 and the AVF is showing positive. So QRS axis is also normal. And what about is there an LVH? Is there any, but voltage there is no LVH. But what is happening in the ST segment? Look at the lead 2, lead 3 and AVF. There is ST segment is elevated in lead 2, lead 3 and AVF. I already told that lead 2, lead 3 and AVF is representing the inferior wall of the heart. So here we have a ST elevation in lead 2, lead 3 and AVF. So it indicates an inferior wall myocardial infarction. It is an ST elevation MI of inferior wall. So usually when inferior wall and ST elevation in 2, 3 AVF is there, you may get an ST depression in AVL as well as in lead 1 also. Similarly in V2, V3, V5, V4 also, because this indicates reciprocal changes and the posterior wall involvement also. Because in the surface ECG we don't have a percentage of the posterior. We have to take a posterior V7, V8, V9. Suppose we have a V7, V8, V9. This ST depression, the V1, V2, V3, because it is anterior leads will show us a ST elevation in the posterior leads. So this is in a patient with the ST elevation, inferior ST elevation, we can have a ST elevation in the 2, 3 AVF, ST depression in AVL as well as in precoidal leads. So here this is a ECG of a ST elevation inferior wall MI. So here what is happening? This is another ECG. Here what is happening? Here you can see there is a ST elevation in the V1, but more strikingly there is significant ST depression. There are 4 millimeter ST depression in V1, V2, V3, V4, V5, V6, as well as 1 AVL and also lead 2 and AVF. So this ECG. Actually, if I am asking this ECG or the previous ECG is more dangerous, I would say this ECG is more important because this sort of change, this is pan-ST depression, and you can see the AVR also. The AVR also showing ST elevation. So when you saw multiple precoidal ST depression with ST depression in the inferior leads and ST elevation in the AVR, this indicates a very, very proximal occlusion in the LAD or a left main. So it indicates a very huge ischemia of the myocardium. It is actually non-SC elevation MI, and probably the occlusion will be very proximal in the LAD or in the left main, and it indicates very significant. We should be with the patient. We should be alert the cardiologist, alert the system, and anytime patient can develop a pulmonary edema or any VT, VF. So this is important of identifying this sort of ECG changes in a post-operative patient or in any other patient. Okay. Now coming to T waves. So T wave also it can be normal, or it can be inverted, or it can be tall. So this is the usual normal ECG. Here the T wave is normal, and look at this ECG. Here the T wave is actually inverted in the V1, V2, V3, V4, V5, V6, and also one avian. So when you get this sort of T inversion, it's a symmetrical T inversion in the precoid list. This is also an important sign. This is also indicates, otherwise you will call, suppose the patient is having a chest pain and we get an ECG like this. This is what we call a valence sign. This also indicates a LAD occlusion. So this is also important. This is a deep symmetrical, it indicates ischemia. So what are the other differential diagnoses when you get this sort of ECG change? In otherwise asymptomatic patient, suppose there is no history of chest pain, no CAD, you are getting this sort of T inversion, a precoidal deep T inversion, then we should, this is actually, that may be a sign of a HCM, especially an apical HCM patient. In apical HCM patient, you will get a deep T inversions in the precoidal leads. So these are the importance of identifying this sort of deep T inversion. But there will be minor T inversion, very small, less than 2 millimeter or 2 millimeter. So small T inversions normally in patients with many patients in V1, V2, V3 or the lead 3 AVF and all, that all normal thing. But whenever you get a significant T inversion like this, deep symmetrical or deep T inversions, you look for pathological features. You can ask for an echo to rule out ischemia or warm motion abnormality or hypertrophic cardiomyopathy, etc. Okay, so what about this ECG? We can read this ECG in systematic way. So look at the standardization. Okay, 25 millimeters per second, 10 millimeter is okay. Is it a sinus rhythm ECG? Yes, it is a sinus rhythm ECG. The P wave is okay. Is there any lead displacement here? No. The P wave is negative. QRS is negative in AVR. So it is hopefully it is a properly taken ECG. It is a sinus rhythm ECG. P wave is upright. QRS is upright in 2. So it is a sinus rhythm. Each P wave is followed by QRS comma. So it is sinus rhythm. What is the rate in this ECG? Right? It is 1, 2, 3, 4, roughly 4 or 4.5. So roughly around 75, 80 per minute. Sinus rhythm around 80 per minute. And is there any left atrial enlargement? Look at the V1. That the slope is little bigger. So probably a left atrial enlargement will be there in this ECG, in this patient. So what about QRS? QRS complex? QRS duration is normal because it is less than 3 small squares. And what about QRS axis? Lead 1 and AVF is showing a positive complex. So it is QRS axis is normal. So what about, is there any LVH in this patient? Look at the V1 and AVL. Here it is 15 and here it is 10. So 10. And maybe 30, 36. So maybe a bottling LVH should be there in this patient. So what is striking? There will be ST elevation and biphasic T. There is T wave inversion is here, and there is a loss of R wave in V2 and V3. So probably this will be a evolved anti-rival MI. Here the ST elevation, there is ST elevation in V1, V2, V3 and all. So, and there is a loss of R wave in V1, V2, V3, and there is a T wave inversion, probably a biphasic T wave, or T is getting inverted in this precoid list. So probably it will be an evolved anti-rival MI. So when you get this sort of ECG in a perioperative period, ask for the history of CAD. If there is no such, ask for an echo. There will be a warm motion abnormality in the LAD territory. Look for the LV function, all those sort of things. And what is this ECG? This is actually very important ECG in the emergency setup or even the ICU setup. Here I am directly going to the T wave. You can see a tall peaked T waves. So what does it indicate? A tall peaked T wave. Usually it indicates a hyperkalemia. So now coming to QT interval, it is measured from the beginning of the Q waves to the end of the T waves. So we have to correct it. So suppose the patient's heart rate is 60 the QT interval will be that measure interval only. But we have to adjust the QT interval with the heart rate. So there is a formula for the QTC, that is QT interval is QT interval divided by square root of R and root. But it is automatically calculated and measure, and it will be written in the ECG. Look at the QT interval. So corrected QT interval, it will be less than 440 milliseconds in male, and normal will be less than 440 milliseconds in male and 460 milliseconds in females. So look at this ECG here. The QTC, it will be the QT interval will be less than 400 milliseconds only. So it is that QT interval is normal. So look at this ECG. The QT is really prolonged. Already it is 3 big squares. 3 big squares means it is 600 milliseconds. The QT is already prolonged. So when you get a prolonged QT interval, so the most common scenario of prolonged QT interval in a ICU setup or in a perioperative this thing is electrolyte imbalance, especially hypokalemia. So whenever you get this sort of ECG, this sort of prolonged QT interval, check the electrolytes first. It can be a hypokalemia or a hypocalcemia or a hypomagnesemia. And other important things are even ischemia can produce QT prolongation. So what are causes of long QT? It can be hypokalemia, can be hypocalcemia, can be hypomagnesemia. Then long QT syndromes. Then drugs like amiodarone, suppose the patient is on amiodarone, it can produce drugs like quinine. It will produce prolonged QT. Then ischemia can produce prolonged QT. And sometimes raised ICT. Suppose many times the patients with subarachnoid hemorrhage or large eyes bleed and the raised ICT will be having prolonged long QT interval and T waves. It is otherwise known as CVA T waves. You might have that term. So now coming to VU waves, it is immediately follows the T waves, and usually it is the same direction as T waves, and best seen in lead to V2 waves. So what is the importance? Usually this sort of U waves is seen in patient with a hypokalemia, and suppose you are seeing a U wave inversion, that usually indicates an ischemia. So that is the importance. There is not much importance, but only thing is if you are seeing a prominent U wave, look for the hypokalemia, and if you have seen a inverted like thing, you look for a ischemia. So coming to so what are the features of a normal ECG? So patient is, the normal ECG will be in sinus rhythm. The rate will be between 60 and 100. The P wave will be normal. That is height and width will be less than 2.5 or 3 small squares. PR interval will be 120 to 200 milliseconds. PR segment should be isoelectric. QRS duration will be less than 110. Axis will be minus 30. That is a normal axis. So we are looking in the lead 1 and the AVF. If both the QRS complexes are positive, the axis is normal. So morphology, with normal morphology and normal progression. Now, what is normal progression? Usually the V1 will be having the smallest RVR. The height will be increasing and reaches the peak by V5 or V6. Then the ST segment will be isoelectric. Then T wave will be normal, and the QT interval also will be normal. That is less than 440 milliseconds in male and less than 440 milliseconds in female. So then I will conclude with the certain normal ECG variations also. So sinus tachycardia can be normal variations in a otherwise normal patient. Sinus bradycardia also will be, many times it will be physiological, especially in the patients of manual labor or athletes patients coming, and there will be the ECG rate will be around 45, 40, 50 only. So the sinus bradycardia can be also a normal variation only. And sometimes sinus arrhythmia, especially people, the heart rate will be varying with the inspiration. Inspiration will be showing a higher rate, and the expiration will show a slower rate. So that is sinus arrhythmia. Then early repolarization, it is also normal. Then isolated atrial primitive complexes and ventricular primitive complexes are normal. The small T inversions in lead 3, AVF for V1, V2, V3 is normal. Then first degree heart rate maybe 200 to 30 milliseconds, it is normal. Then LVS by water KK in sing chest wall individual. But in usually in 20s and 50 or 20-year-old thin chest patient can there will be having a voltage LVS by voltage criteria. That is also normal. Then indeterminate axis. What is indeterminate axis? Because all the QRS complex in limb leads will show a biphasic leads. That is also a normal phenomenon in many persons. Then incomplete RBB, because the ECG will be showing an RSRS pattern, but the QRS duration will be not more than 120 milliseconds. That is an incomplete RBB. That is also a normal phenomenon in many persons. Okay. So this is one ECG of the early repolarization. You can see the look at the lead 2, 3, and it will interpret as in ST elevation. So what is involves here that ST elevation? That ST elevation, you can have a J wave in the beginning, and it is a concave up ST elevation. And at any doubt, we can look for an echo, or you can look for enzyme also in this. This is the most common scenario of chest pain and confusion in the emergency department, early repolarization. Okay, so Sanish, I will stop at this point. Then maybe we can discuss in an interactive session.
Okay, fine. Thank you very much. I think Dr. Shifas has taken a huge task of revising all the basics in ECG interpretation. I think most of the things are covered, like in suspense thriller. This webinar is available on YouTube. So those who found it a little bit faster to catch up, whenever you look back, all the details must be there in the video, I think, Dr. Shifas. So anyway, we'll proceed to, we'll go to Dr. Manjunath for a scenario discussion. So whenever we discuss the scenarios, most of the points discussed already will prop up again. We'll find out if you need more clarification or more detailed explanation. Dr. Shifas will also join. And I'm also honored to identify the presence of Dr. B. Radhakrishnan. Sir, would you like to speak a word before we go to the interactive session? Radhakrishnan, sir.
Thank you very much. It's going on well. Congratulations. Okay, go ahead.
Okay, over to Manjunath, sir, for scenarios discussions.
Sanish, can you hear me?
Yeah. You can start slideshow.
Sanish.
Yeah, same.
Slideshow. This will start.
Yeah, you can go to the.
Yeah, good evening, dear all. Yeah. Good evening, dear all. Greetings from Mysore Medical Department. Good evening, sir. Radhakrishnan, sir. Good evening, sir. My senior professor. So today, I think most of the ECG is explained beautifully by our Shifa. He has told extensively regarding the ECGs. What I'll do is my first 15 to 16 slides are similar to Dr. Shifa's slide only. So we'll firstly go through that, and just a few slides will go stress upon that. My topic of discussion is just like that basics. He has already told everything. So what I'll do is, so what are the common arrhythmias which we encounter in the operation theater? So that I'm going to discuss. So regarding the atrial, regarding the arrhythmias, we're going to discuss in detail. And I'll touch upon a little bit about defibrillation and cardioversion and AEDs. Just I want to go to that as for the benefit of the postgraduate students. We're going to tell about these three differences between these three things. And then later, after that, I'm going to touch upon the atrial fibrillation in detail. So, and at the end of my talk, we're going to post some scenarios. So for that, our postgraduate will going to answer that. So as Dr. Shifas told, they're going to tell in the systematic manner is the systematic way of interpretation of the ECG will be there. They're going to tell us. So in that way. So first and foremost thing is, as basics, as I said, the calibrations he has done beautifully. So everybody knows it, paper speed and big small space. So voltage will going to be a y-axis and the time will be the x-axis. Everything they're going to, and he has they spent beautifully going to go into the details of these things. So this also is what are the normal ECG, what are the qualities of the ECG, and what are the waves, PQRST waves. The P will be followed by QRS complex, that is the normal ECG, and the intervals, what he has said in the intervals, to know about in detail about the PR interval, QRS duration, and the QT interval, everything you should know in detail. As far as the normal ECG is concerned. So the next, what I'll do is, this is the thing which everybody, all the postages were asking for that. So we have got two formulas, as I said, as Dr. Shifas already discussed in detail. So every postgraduate during the examination, they're going to ask, how will you going to calculate the rate? So we have got the small rate. So we're going to talk about this ECG, we're going to post it. Can our postgraduates, can anybody talk? Dr. Nisha? So we're going to calculate the rate. This is Dr. Nisha.
Hello, good evening. Sir, first,
This is already shown in the figure. Just explain it.
yes, sir.
Nisha, can you hear me?
Yes, sir, I can hear you.
Nisha? Yeah.
Hello.
Hello.
Yes, sir. So the formula is
Dr. Nisha, you are not audible. You need to speak loud or.
Nisha?
hello, sir. Can you hear me now, sir? So the first graph shows number of boxes, 2 are number of boxes, 4. So 2 divided by 4. So the heart rate the first 5 in the second one.
Sanish, audible? Is audible, Sanish?
No, it's not audible. Sir. From participants, anybody else is willing to volunteer?
Participants already calculated. Only thing is they have to explain it.
Yeah.
Participants? So Nisha, Shilpa?
Hello, sir.
Yeah. You're audible. You can speak.
Yeah, Shilpa is audible.
Yes. Sir, in the first one.
Hello, Shilpa?
Hello, sir.
No, it's yeah. Yes, you are audible.
Yes, sir.
Go ahead.
So in the first one, the number of large boxes. So the hello, sir. Hello, sir.
Hello.
Sir, is it audible?
Yeah. Sanish. So I'll go to the next sheet. So self-explanatory, everything is explained. So So 300 divided by the number of between the RR interval, you have to take as a smaller big squares. 1, 2, 3, 4. This is the first slide. I think this is the slide first. Here, audible? Okay.
Nisha, you are using headphone now?
Yes, sir.
Nisha, do you think headphone? Yeah.
Yes, sir. Can you hear me now, sir?
Yeah. Yes. Speak loudly.
So the formula is 300 divided by the number of big squares, sir. So in the first strip, the number of big squares are 4. So 300 divided by 4 would be 75. Whereas in the second square, the number of big squares are 6. So 300 divided by 6 would be 50, sir.
Okay. In third one, it's only number of.
Third one, sir. Third one, number of big boxes are 2. So 300 divided by 2 will be 150, sir. The heart rate is 150.
Okay. So axis, I think you have described beautifully regarding this frontal QRS vector diagram. It has to plotted. So that thing is there. So the normal axis is between the 30 to 90 degree. That is there. So he has described it beautifully. I don't want to go into the details of this axis. The simpler methods, what I am doing is, so this is the way you have to quantify it. This is R waves QRS complex, predominantly positive, predominantly negative, and equiphasic. These three things you should be able to identify it, whether it is a negative deflection or a positive deflection. I don't want to go into the electrical activation of that. So whenever there is electrical current going towards it is positive, going away from it is explained beautifully by Shifas. I don't want to go into the details of that one. No, this is the normal axis. So 0 to 90 degrees is a normal axis. 0 to 90, minus 90 is the left axis. So what you do is you have to look at the lead one and lead AVF. I will going to tell you the simplest one, which one lead 1 and lead AVF. So that I has described already. So next, what I'll do is whether lead 1 and lead AVF, look where lead 1 and AVF are pointing any ECGs. Okay. First ECG I'm going to like this. So look at this, both pointing upwards. It's a normal axis. I think everybody agree with that. So it is a normal axis. Look at 1 and AVF both. So R wave is looking at is pointing towards same. It is a normal axis. The next is the both 1 and AVF leaving. So it is lead 1 the cure is the R wave is towards the right side, and the study is going up, that is a positive, and the LAVF it is going downwards, that is left axis deviation. Either the best mnemonic is left leaves. Okay, so both towards that. Left leaves means it's the left axis deviation. Right reaches, next is the right reaches. The next one is the right axis. Both are reaching toward the right reaches. It's called right reaches and left leaves. That is the mnemonic. You can keep it. Always look at the lead one and AVF. You can able to identify the axis. But the importance of which I think he has already explained beautifully regarding the importance of this axis. There's nothing too much in this, but especially there are some situations as Dr. Shifas emphasizing the importance of axis. Everybody should know that. Okay. So next we'll come to the scenarios in regular. So the rhythm, as per the rhythm is concerned, I will go in detail in the rhythm of this ECG. So whether you look at the rate, after rate you have to come for the rhythm. During the rhythm, whether you have to identify the particular ECG, whether it is a regular or whether it is a irregular. So regular, I don't know, I think everybody knows it and he has detailed explained. Now, I'm going to ask our postgraduates, so what are the causes of these arrhythmias, intraoperative important arrhythmias? Can you able to, what are the causes of intraoperative arrhythmias in our routine practice? Nisha? Nisha? Can you able to classify the arrhythmias? Yeah,
Yes,
first what you do is,
suppose we take the AV node as the center, any arrhythmia which is arising above this AV node will be supraventricular, sir. Anything at the AV node will be junctional arrhythmias, and anything below the AV node will be ventricular arrhythmias, sir. And in each of them, we have tachyarrhythmias and bradyarrhythmias, sir. This is the broad classification, sir.
Okay, so you classified very nicely. The arrhythmias, nothing but the disordered rhythm. The rhythm of the patient, the rhythm of the ECG strip is rhythm is normal, and it is only going to have irregular rhythm. It's called irregular rhythm. So there are a lot of irregular rhythms. What is the importance of rhythm? Why we should know the rhythms? Why we should study the rhythm? Is it most common in intraoperatively? Nisha? Shilpa? So arrhythmias are most common intraoperatively. Hello? See this?
Hello, sir.
Yeah.
Yes, sir. Sir, arrhythmias are common during intraoperative period because of the procedures we do, like laryngoscopy and intubation. The anesthetic agents we use, like hallucinated hydrocarbons like halothane and muscle relaxants like scoline. And this halothane sensitizes the myocardium to both endogenous and exogenous catecholamines. And reflexes because of vagal stimulation, oculocardiac reflex and nasocardiac reflexes. And patients having pre-existing cardiac diseases like valvular heart diseases, myocarditis, and hypertrophy, and disturbance in the serum electrolytes, mainly potassium, magnesium, and calcium, and procedures like hypoxia, hypercapnia, and even the acidosis. All this can predispose patients for arrhythmias during intraoperative.
Okay. So do they have any harm regarding that? Why should we treat this? Should we identify the arrhythmias intraoperatively? Do they have any problem? What are the importance of identifying and treating that? Why should we treat arrhythmias?
Sir, because these arrhythmias can cause hemodynamic effects, leading to decrease in the cardiac output, and they cause derangements in the oxygen demand and supplementation. And because of that results in the loss of atrial kick. Because of that, the amount of cardiac output will be decreased, and the chance of developing ventricular fibrillation will be more because of R and T phenomena.
Okay. The thing is, normally when you are anesthetizing patient under general anesthesia, so there are some hemodynamic disturbances will be there because of the site of surgery, because of the anesthetic agent we use, because of the procedures, vehicle maneuvers we are using. So that automaticity will be lost in this cardia. So we have to treat these patients. So whenever, what is the treatment modality? Usually these normal reflexes will be tolerated very well tolerated in a normal myocardium. But if these reflexes, if these arrhythmias occur in a patient who has got a pre-existing cardiac disease or in a valvular heart disease, a minor arrhythmia may be very dangerous. So it will go to herald this voluminous ventricular fibrillation in future. So he had to treat it. First and foremost thing is, whenever we encounter arrhythmias intraoperatively, first thing you should look at the hemodynamics. If the patient is stable, if the blood pressure is stable, if the cardiac output is stable, and don't do anything at all, normally there is no need of treatment of any arrhythmias intraoperatively. But whenever there is a patient with a pre-existing cardiac disease, or a known patient with a valvular heart disease, or any myocarditis during like that only, then you have to identify these arrhythmias and you have to treat it. This is very, very important. And as far as Dr. Shilpa has told, the cardiac output will be affected first. Second thing is the delicately balanced myocardial oxygen supply demand ratio will be lost during this one. What is meant by atrial kick? That atrial kick will be lost in situations like mitral stenosis or any other diseases. So this, the mitral kick, this atrial kick, which is responsible for ventricular filling, will be lost. So you are going to have effect on cardiac output. Second thing, the effect of bradycardia and tachycardia will be well and well. I think is explained by on the cardiac output is definitely is there. So I think Dr. Shilpa will going to explain what are the effects of bradycardia and what are the effects of tachycardia and cardiac output as far as arrhythmias are concerned.
Sir,
Dr. Shantala? Or you can explain, Shilpa only explain. Hello, Shilpa? You know. Hello? Hello? Can you hear me, Nisha? No, Shilpa only explain. Now, only thing is, whenever there is a bradycardia is there, those patients who require adequate cardiac output for the maintenance. For example, there is so many diseases in the cardiac, so this adequate heart rate is very, very important for the maintenance of cardiac output. So in these patients, the rate is very, very important. So that if there is a bradycardia, the cardiac output will be suffer. As far as the tachycardia is concerned, you would have the diastolic time, the filling time will be decreased, and the tension time will be decreased. So there won't be much time for the filling of this ventricle. So the both tachycardia as well as the bradycardia is worst for these patients as far as the cardiac output is concerned. So you have to be very careful and treat these arrhythmias very fast. Okay. So now come to the irregular rhythm. We have got different types of rhythm. This is called what we call as a regular rhythm. This is a nice looking ECG, as Dr. Shifas already explained on this one. And it's a nice looking and everything is all right. The QRS, P wave is followed by regularly followed by QRS complexes. All the waves are present. PQ, RST, all are present. And this is the regular rhythm of the particular patients. There are the irregular. When there is a rhythm is irregular, we have got, so there are the examples. Can you able to go there? So these are the irregular rhythms. The examples of the irregular rhythms are atrial bigeminy, ventricular bigeminy, and ventricular trigeminy. We'll go to explain it later. And the third one is ventricular couplets, ventricular triplets, polymorphic VPC, R-on-T phenomena. I'll go to explain what is meant by R-on-T phenomenon and polymorphic VT. So each one will come into the scenario and go to explain what are the description. First and foremost thing is you have to describe it and you have to identify it and then treat it. There are three things are there: identification, description for its diagnosis, and the third thing is treatment for these pairs. We'll go in detail regarding this. So next comes the bradyarrhythmias. The first one is the tachyarrhythmias, now bradyarrhythmias. For the bradyarrhythmias, this is the sinus bradycardia. Rate is about 43%, 3 beats per minute. Each is complex. I think it is self-explanatory. Everything is given on that. This one is the first degree AV block. So can anybody go comment on the first degree AV block? What is the description of the first AV block? Can anybody? Voluntarily? First degree AV block. Can anybody comment on first degree AV block?
Hello, sir.
The first question is, first question is, what is the heart rate and is it regular? The first question is, what is the heart rate in this? Is it regular? What is the heart rate? First degree advice. First and foremost thing is, you have to go for the rate. What is the heart rate? Is it regular? So heart rate is slow. Okay, I'll agree to slow to normal. Heart rate is slow to normal and the rhythm is regular. Okay. So we have got regularly regular and irregularly irregular. Okay, this is the heart rate is normal. Our heart rate is very slow to normal, and the rhythm is regular. Is the QRS complex wide or narrow? Next question is the QRS complex wide or narrow? Anybody? Nisha? The QRS complex is bit narrow. It is not wide. Okay. Okay. What is the are P waves present or upright? The next question is. Hello.
Yes, sir.
Are P waves? Are P waves present or upright? In this P waves are upright. Okay. Yes. What is the relationship between P waves and QRS complexes?
So 1:1.
Just look at the difference, the relationship between the P waves and the QRS complexes. Is fixed. Okay. Yes. There is a fixed one relationship between P waves and QRS complexes. It is fixed. Just look at the P wave and QRS complexes. Okay. Just look at the P wave and QRS complexes here only. Yes. Can you be able to see that?
Yes, sir.
Okay. So what is the description? You can say every P wave causes a QRS complex in first degree AV block. Okay. And the PR interval is fixed, but is greater than 0.2 seconds. Yeah, anything, Shifas, you can able to comment on this, Shifa, Dr. Shifa?
Yeah. So this ECG, as you told, it is a sinus rhythm because the PR's axis is normal and PR is well marked. 8 complex and 320 millisecond QRS complex is normal, axis is normal, and QRS axis duration is normal. And actually, it is and each PR is for the QR complex and the PR under, even though it is prolonged, it is fixed. It is so it is a first degree block.
Okay.
Yeah.
So, okay. Anything you want to add it regarding the first degree block?
No, sir. We'll proceed.
Yeah. So, yeah. This is the next ECG. So, anybody comment on this? The Nisha? AV block. What is the heart rate and is it regular? The first question is what is the heart rate? Regular.
The heart rate is irregular, sir, and the heart rate is slow to normal, sir. And some of the QRS complexes are missing.
What about the rhythm? What about the rhythm? Rhythm is not?
It's not regular, sir. Rhythm is not regular.
Rhythm is not regular. Okay, because QRS complexes are missing. Some of the QRS complexes are missing here. Okay.
Yes,
some of the QRS complexes are missing here. Okay. In this space, every third QRS is missing here. Just
yes, sir.
Look at this. Every third QRS complex is missing. Okay. Okay. Is the QRS complex? Next question is the QRS complex narrow or wide?
So it's usually narrow, sir.
So usually like this, look at the ECG and tell me, is the QRS complex wide or narrow?
Narrow, sir, narrow.
It's narrow, sir.
So it is typically narrow. So okay, it is little bit slightly widened, but it's still narrow. In this situation, this ECG is typically narrow, but little bit widened. Okay. Okay, are P waves are present and upright? Next question.
Yes, sir.
What about the P waves?
Present, sir. The P waves are present and they are upright, sir.
Okay. What is the relation between the P waves and the QRS complexes now? Next.
So in this, we have more of P waves than QRS complexes, sir.
Yes. One thing. Second thing.
And the PR interval is progressively increasing, sir.
What are the PR interval?
The PR interval is progressively increasing until there's a loss of QRS complex,
sir. Tell me some description regarding the second degree AV block.
Sir, the second degree type 1 AV blocks is also called as Mobitz type 1 or Wenckebach phenomena, sir.
Wenckebach phenomena, yes, it's also called Wenckebach phenomena.
The conduction block occurs in AV nodes, sir.
Okay.
And the PR interval progressively lengthens until the impulse is not conducted to the ventricle, sir.
Okay. Okay. Any other points?
It is most commonly associated with right coronary artery occlusions with inferior MI, sir.
Okay.
But this has a good prognosis, sir.
Okay. Sanish,
Sir, I have unmuted one more participant, Dr. Benita.
Okay.
She will also participate in the interactive discussion.
Okay.
Dr. Benita, can you introduce yourself?
Yes, sir. Hello, sir.
Yeah.
Yeah.
I'm
Introduce
Dr.
yourself.
Vinita. Yes, sir. I'm Dr. Vinita, post SR in Delhi.
Okay. Can any comment on this? Any other things to comment?
Sir, can I comment one thing, sir?
Okay.
Sir, can I comment on?
Yeah.
Yeah. Okay. So this is actually there is progressive prolongation of the PR interval and till one QRS is missing. So it is a second degree heart block and it is a type 1 or second degree heart block. Here actually it is easy to identify whether it is type 1 and type 1 not type 2. Because the QRS the missed QRS complex is after third beat. Suppose there is each alternate beat is missing. Then how to identify whether it's a type 1 or type 2? That is one thing. Because the importance is that the type 1 is usually little benign and type 2 is actually more serious. So that's it. Because as the previous speaker told, usually inferior alignment, this sort of this thing, this sort of IV block is in. So how to identify a type 1? Whether it is a type 1 or type 2 secondary heart block when every alternate P wave is missing, because if you have 2 or 3 P wave consecutive, then we can understand identify the progressive prolongation of the PR interval. Suppose this is prolonged and this is missing, then again this one and again that is missing. Then how do you understand, identify whether it is a type 1 or type 2? That is one question. In that case, the thing is, if it is a type 2, the gap will be exact multiple of the previous two QRS complexes, PP intervals, exact multiple. If it is type 2.
This is the second one. So what is the criteria to say it is on Nisha or Vinita? Anybody can take on that. What is the heart rate and is it regular? Now my first question is what is the heart rate and is it regular? Anybody? Tanish, you introduce one of our postgraduates.
Sir, heart rate is normal and it is regular.
Okay. Slow to normal, rhythm is it regular? Heart rate is regular. Just look at the heart rate. Rhythm is not regular here. Okay, just look at the heart rate. Rhythm is not regular. Just look at the rhythm. PQRST. Just follow this principle. Okay, Nisha? Heart rate is regular or not? Our rhythm is not regular. Heart rate is slow to normal and rhythm is not regular. And a little bit here also the QRS complexes are missing. And QRS complex compared to previous one, it is a little bit wide. Okay. And PVRs are upright. And there are more PVRs compared to the QRS. Sanish?
Yeah.
Please, you only explained it. And Sanish and Shifas, anybody?
Sir, shall I make one comment?
Yeah.
Please.
So whenever you get an ECG with this sort of grouped complexes, that is some 3 beats, then a gap, then again some 3-4 beats, then a gap, then again. So whenever you get a ECG with this sort of grouped QRS complexes, suspect this sort of second degree heart block, especially Wengi-Back phenomenon. Whenever you get this sort of grouped complexes, you look carefully whether the PR interval is constant or PR interval is prolonged. Because every time in Wengi-Back period that ratio will not be same. Sometimes it will be the P will be missing after 2 beats, sometimes it will be missing after 5 beats, like that only. But whenever there is a Wengi-Back phenomena, you will get a grouped complexes in the ECG. That is what I want to mention.
Okay. PR interval is fixed, I think, till this impulses will go into the travels to the ventricles. The PR interval will be fixed, I think.
Yeah. One more thing I would like to remind the residents is rhythm we are checking in the lead 2. So whether it is regular or irregular, you can mark the R waves and see whether R wave falls on regular intervals or there is a progressive change or something is missing in between. So you look at lead 2 only when you answer the question whether it is regular or irregular.
Okay. Regarding this, Sanish, the Shifas, the high grade AV block.
Yeah. By definition, when two or more P waves are not followed by QRS, it is a high degree AV block. When two or more successive P waves is not followed by QRS complex, it is a high degree.
I don't know the. I took it from one of my cardiologists. I don't know the exact implications of this high grade AV block regarding this. Any implications?
No, sir. High grade because it denotes, it indicates a pacemaker implantation. High grade means if it is not a reversible thing. Because here actually three players in this, you see, three players are not followed by QRS complexes. Yeah, this is third degree. Yeah.
Okay.
And so just previous slide, sir.
Yeah, this is the one.
Yeah, previous one.
This one.
Yeah, previous one.
Yeah, this one. This one.
No, still it's showing third degree.
Third degree.
Previous slide. Yeah.
The next one, second degree.
Next one.
This is the third degree AV block. Okay, can you comment on this, Nisha or anybody? Our postgraduate.
So this is the third.
No, you comment on this. What is the heart rate? Look at the heart rate. It is regular or not?
The heart rate is usually slow to normal, sir. And here the rhythm will be regular, sir.
Yeah.
Okay.
And the QRS complex is usually wide. The QRS complex is wide here, and the P wave is upright, sir.
Here in this ECG, QRS complex is wide. In this ECG,
a little bit.
In this, no, sir. In this, we don't know, but usually we have QRS complex.
This is what I told in my talk. Because in this ECG, this is actually a complete block because there is no relation between the P wave and the QRS, and QRS is regular, P wave is also regular. But there is no relation between P wave and QRS, a total dissociation. But the QRS is narrow. So this indicates that this QRS complex is originated from above his bundle. It is actually suprahischian escape rhythm. So the peculator or heart is when one pacemaker is not functioning, the next higher pacemaker will take over. So here the block is above that. So that's why we are getting a narrow complex. So this complete block is having a better prognosis than a complete block with a wide QRS complex. That is the important. So usually, suppose the patients have a congenital complete block. Children may have. So this complete block sometimes responds to atropine also. It is not like the other complete block. So when you have a complete block with a wide complex, it is more unstable. This is a complete block with a narrow complex. So here it is actually a suprahischian complete block. That is important in this ECG.
Okay, one more thing I would like. One more thing I would like to add. Like when postgraduate is given an ECG, you need to speak on that particular ECG. You can't generalize things. In exam also, if you are given an ECG, you speak on that ECG only. Okay, because diagnosis comes later.
Three ECGs, the third degree.
Yeah.
The second is the PP interval is fixed. So that is the one constant PP interval. Okay, third ECG is the varying PP interval. So as Dr. Shifas was doing that AV block, Shifas, can you comment on these three ECGs, at least first, second, and third one, varying PP interval?
Which one, sir?
Dr. Shifas?
This one.
This is the one, the ECG with the third degree AV block. Yeah.
Okay, this one actually, this ECG is showing P waves, but the P wave and the QRS relation is not constant. So that means that this QR, the QRS, the first QRS is not because of the conduction from the P wave. So both are independently coming. So there is a dissociation. Yeah, and another thing is the QRS is narrow. So the complete diagnosis is it's a third degree half block, complete half block with a and it is suprahischian. That's all.
Okay.
Yeah.
Okay. Thank you. This is the one which is a complete heart. So we'll come to that. So
another thing is Yeah, and one more thing. Suppose you are getting this sort of white complex and there is no P wave, then what will be the diagnosis?
Okay. The complete
there is no P wave at all. Only QRS complex and this rate. Patient is otherwise okay.
Dr. Binitha, you want to take this question?
Binitha?
Sir, premature ventricular complex.
No, ECG only showing this QRS complex, white QRS complex at a rate of 40. No P waves.
So maybe the sinus.
Yeah, that's all. If P wave is not, that means that the sinus node is not functioning. So it can be a sinus node dysfunction, or it can be atrial fibrillation with a complete block. That's all. Simply you think that's all. Yeah. So when you have the P wave only, we can tell, we can identify the AV dissociation. If there is no P wave, we cannot. We can have only different diagnosis, differentials. Yeah.
Can you comment on this, Nisha?
Hello, sir.
Yeah.
Hello.
Electrical activity. Yeah. Can you hear me? Pulseless electrical activity. What are the types of cardiac arrest, Nisha? You know?
Hello, sir.
What are the types of cardiac arrest? So I'm not asking the questions. What is the causes? What are the types of cardiac arrest?
Hello, sir. The most common cause for cardiac arrest is ventricular fibrillation, sir. 90% of the cardiac arrest occur because of ventricular fibrillation, sir. And other causes are pulseless VT and VF, sir, and asystole.
Okay. Okay. And
actually, the question is, how do you define pulseless electrical activity?
Yeah. I asked in another way around. I asked, what are the types of cardiac arrest?
Any suggestion?
Anybody for that matter? Shifas, you only have to explain. Shifas? Yes. Shifas is here ready.
So this ECG, nobody there to take.
Okay. Cardiologist is there for that. That's why just
so what is this ECG showing? So we will go systematically. Anyway, there is no standardization. Yeah, standardization is there. It's okay. And what is it showing? There is no P waves. And yeah, there is no P waves, and the rate is very slow. How much is the rate? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 10, 11. So it is less than 20, less than 30 rate only, and less than 30 rate only, and QRS is wide. So it is a rhythm originating from, there is no P wave. So atria is not firing, so nothing is coming from the atria. Ventricle is, the rhythm is coming from the ventricle because the QRS is wide, and it is a very slow. So it's a very slow escape. So it's a like things of the patient, and when you get this sort of AC, you have to see the patient, whether the patient is having any pulse, all these things. Yeah. So yeah, it's a pulseless electrical activity. Yeah.
I think whenever you get
like an angle, yeah, it's less like an angle rhythm from the ventricle.
I think whenever you get any kind of organized rhythm, and you can't definitely feel a pulse, it is called pulseless electrical activity. Be it bradyarrhythmia or sinus rhythm or ST elevation, whatever you see on the monitor, there is no central pulse at all, or you are not definite about the pulse. It's termed pulseless electrical activity or PEA. Correct?
Yeah. Yeah.
Okay. Yes. Thank you. We'll go to the move to the hyperkalemia. I think
can I make one comment? Can I make one comment?
Yes.
Yeah.
Actually, in between, in one of the slides, we were discussing that R1T phenomena. So we have to, what is R1T phenomena? If the P wave is, if the QRS, the ventricular ectopic is landing on the T wave, it will produce a ventricular fibrillation. That is why ventricular fibrillation, ventricular tachycardia. That is what RMT phenomenon. Exactly, this is because this is why we have that synchronized and non-synchronized shock system in our defibrillator. Because whenever you have an identifiable QRS complexes, you should use a synchronized ventricular shock, synchronized shock, because if your shock is delivered on the T wave, the patient will be under the fibrillation. Whatever be the arrhythmia there, it will produce ventricular fibrillation. So because of that, whenever you have an identifiable definite QRS complexes, you should use a synchronized rhythm. You can use a non-synchronized DC shock when you have a when you don't have a well-formed QRS complex, especially polymorphic BT and BF. Just I want to make that comment. Yes.
Yeah, so after this, I'm going to tell the DC regarding the defibrillation, cardioversion, and AED. During that period, I will going to talk on this R&D phenomenon.
Yeah,
just I want to tell that.
Okay. Yeah.
Period is showing the hyperkalemia features. So, can anybody take on this? This and explain the features? Can anybody? I think already is Dr. Shifas already told regarding the hyperkalemia features. What are the features of hyperkalemia? Detail. So, anybody on that audience, our postgraduates?
Sir.
Nisha?
Hello, sir.
Yeah. Anybody? Okay, no problem. Yeah.
Sir, here
yes.
the QRS complexes are wide, sir, and T waves are tall, and the PR interval is also prolonged, sir.
Okay. So the only thing is that whenever you find a picture like this, they're going to ask you regarding hyperkalemia. What is the normal potassium level? What is the when it is you call it as hyperkalemia? When you call what is the normal serum potassium level?
3.5
this question
to 5
will go to definitely going to ask. What is the serum normal?
3.5 to 5.
Yeah, tell me. Yeah, you're right. 5?
3.5.
Equivalent.
3.5.
Okay. When do you call it as a hyperkalemia?
So when it is more than
so next
5
question is what is okay. So what are the treatment for this? What are the causes and what are the treatments? So please go through these things. What are the characteristic features of hyperkalemia as far as the ECG is concerned? They're going to ask you to tell. So in the what is the normal serum potassium level? So what do you call it as a hyperkalemia? What is the treatment for on table? So you have for hyperkalemia. So these things is a short question for all the postgraduates. Please get prepared for this hyperkalemia because we have to go through a lot of other lists are there. Tell me what is this? I think already diagnosis is there.
Sir, this is sine wave pattern.
So next. Okay. So what are the cause of asystole? Hello. What are the common causes of asystole? Anybody?
Hello.
Anybody?
I think
so ECG leads are not proper. Sir, ECG leads are not properly placed.
Yes. No, thing is the isolated pH. The common is the common the so what I want is what I want people to say that there are these different types of cardiac arrests are there. Electromechanical dissociation. This is the basis for your treatment of a cardiac arrest situation, and this is the basis for your CPR. So for that, you should know the rhythms. This is the rhythm showing asystole, and what is the way you go to get with this patient? I will go start your CPR for this patient. Are you going to do defibrillation? Or are you going to do some other things? Anything for that?
So we will start with the CPR.
How will you do start with the CPR? you have got a defibrillation, you have got a drugs, you have got AED, everything on your hand. How will you going to proceed with this? So there is no rhythm at all. First and foremost thing is we have to go for adrenaline. So first and foremost, give adrenaline for this patient. So in IV in intra, I will give adrenaline. How much you want to give? The reason adrenaline. So one month back, it has. I think everyone should go through the 2020 guidelines. Recently, this last month it has appeared in the circulation. Shifas, any comment on this regarding the CPR?
No, sir. Actually,
as far as the cardiologist is concerned, hello.
No, and I think the postgraduate should be clear about the resuscitation things, because basically PE and assistoly we categorize into one group, where the present recommendation says CPR is okay, but institute adrenaline at the earliest opportunity. Just like we say VF, VT, pulseless VT, you try for defibrillation at the earliest opportunity. Okay, both these will have a CPR going on 5 cycles. Like adrenaline, once we give 1 milligram and then follow it up with repeat doses of 1 milligram IV bolus every 3 to 5 minutes. So that will continue while you are troubleshooting regarding the causes of cardiac arrest like 5HS and 5Ts. So adrenaline, the first preferred route is intravenous. If it is not there, the next preferred route is intraosseous. Okay, there is no question of intramuscular. So these things should be clear, and the answer should come promptly, because we are working in acute medicine specialty.
At the same time, you have to know the dosage of adrenaline. How will you going to give? Adrenaline should be taken in an ml syringe, 1 ml, and dilute it to 10 cc and put it. Or else to take 1 ml and put 10 cc of normal. You have to say there is two circulation. You have to push the adrenaline, and then they're going to ask you what are the different doses of adrenaline. What is the initial dosage? The loading dosage? What is the escalating dosage? What are the high dosage? There are some 4 or 5 dosages are there. So please remember. So go through this. Miller has given beautifully regarding the dosage. 3 different dosages are there: initial dosage, loading dosage, escalating dosage, and a very high dosage. 0.1 milligram per kg body weight is nothing but a very high dosage. So please go through this, and everyone should know that regarding the dosage of adrenaline, how will you going to give, and how will you going to resuscitate these patients. Okay, we'll go on to the next.
And one more thing, in some countries we have pre-filled adrenaline syringes. So
yes.
ACLS mega code, you can count the number of adrenaline pre-filled syringes used up during the resuscitation attempt.
Okay. So this treatment options I given it. So algorithm, I'll go directly to the algorithm. So Bredicote algorithm, I think everyone knows. They think that please go through the algorithm in the 2010 guidelines. I think they released the adrenaline. They released the guidelines. So please go through the guidelines and then go to treat on this. So next, so the dosages, everything will be given. Atropine, how to give atropine, dopamine, esoprodol, everything I'm going to give it in through the, I think Dr. You're going to give it in through, I think YouTube writing, right?
Yeah.
This one,
yeah,
my, we'll go to that. So next we'll go directly to the, so atrial fibrillation. Yeah. So can we comment on this, Shifas? If you are comfortable, we can comment on transcutaneous pacing. So because we are not doing much regarding the pacings, if you can able to tell us regarding the pacing.
Yeah, so the transcutaneous pacing actually it is which are used in an emergency setting with this patch and inserter machines. Yeah, but only thing is it is actually only in the emergency setting. As far as possible, we have to go to the usual pacing because it is very painful in a otherwise conscious patient, and we have to select it very nicely. Yeah. And it is very difficult to get that threshold also. That is in my experience. So yeah, so I have very rarely used, only once or twice only I have used, but it is very difficult to use it.
So usually what we
Even
do
though
is, now there is a patient we
available, but it is
evaluation. So when you get a periodic evaluation, the patient is having bradycardia, and you will send it for the cardiologist opinion. And so we will going to have a pacing. They are going to prepare the pacing for the electro. They'll prepare it. Prepare it. They will going to send us to the OT operation theater. If at all, if it is an emergency during the intraoperative period, they will come and they will assist us. This is the way we are practicing in our institution. So okay. So shall we go to the atrial fibrillation? Okay. So when do you say it's a atrial fibrillation? Nisha, can you rhythm? So whenever there is a rhythm is irregular, and there's a varying RR interval is there, there are no definite P waves are there, and usually associated with a fast ventricular rate. So this is the characteristic of a atrial fibrillation. Okay. Next, look at the ECG and tell anybody. ECG. What is the heart rate and is it regular?
No, sir.
What is the heart rate and is it regular?
The rhythm is irregularly irregular, sir.
Yes, very good.
And
whatever
the QRS complex is narrow. The QRS complex is narrow, sir.
Okay.
And there is no P wave, sir. Absence of P wave.
Okay. Okay.
And there's no relation between P wave and the Q wave.
What is it? So, how do you say it is a atrial fibrillation? Okay, let's summarize. How do you say it is atrial fibrillation?
There is absence of P wave, and the rhythm will be irregularly irregular, and there's no relation between the QRS complex and the P wave, sir.
Okay. Shifas, any comments, Shifas? Dr. Shifas? I think Dr. Shifa is muted. Shanish.
Yes, sir.
Yeah.
Yeah.
Dr. Shifa.
Yeah. So ECG with the. So this is fibrillation with the fast ventricular rate.
Okay.
And the hemodynamics, whether the patient is having hypotension or any pulmonary edema or any chest pain, we have to deal it. If it is hypotension, is having high hypotension after developing this fast rate, then anyway we have to shock it.
I think Dr. Shifa has told you, I think everybody will know this, how to calculate a heart rate in atrial fibrillations. I think he has calculated, and I also calculated and kept it right. And please go through this, how to calculate the atrial fibrillation rate of, I think, for about 6 seconds you have to take the big boxes. How many big boxes are there in the? So 6 seconds. He has calculated and kept it right. This is the way you have to calculate a heart rate in atrial fibrillation. Okay. So what are the symptoms and treatment targets? So in atrial fibrillations, if the rhythm control and the rate control, we have got two things are there. Rhythm control should be then, and the rate control. Here rate control should be there. So Nisha, can you explain it? Rhythm control and rate control. Dr. Nisha?
Hello, sir.
It is given. So already the answer is there. Just can you explain it?
Okay.
So I think already explained it. I think they have got a problem with the connectivity. So I only explain. So rhythm control strategies, if there is the hemodynamic instability is there. So whenever there is a hemodynamic instability, then only you have to go for rhythm state. Symptomatic despite rate control. Patient should be have symptoms. Then only you can go for the rate control. If there is a fast ventricular rate is there, so you can go ahead with beta blockers, diltiazem or digoxin should be given for these patients before going on for the other things. If the patient is having pulmonary edema along with atrial fibrillation, please go ahead with the diuretics. Okay. So and you have to be very careful regarding the LV clot and LV clot, because if there is a LV clot, you have to go for echocardiographic echo and rule out LV clot. Then only go for a treatment of these patients. Along with that, anticoagulation is very, very important in these patients. We have to go for anticoagulation. So there I'm going to tell you how will you going to do anticoagulation in these patients. Okay. So some control, that's like and so the dosage is also given, oral route and first dose and follow-up dose. Those things are given in this, I think. Shifa, I think I'll agree with that treatment aspects, Dr. Shifa?
Yeah. Sure, sir.
Okay.
Yes.
So drugs
And
So we are not
one point I have to say, one practical point, while the patient is connected to a monitor, whether it is during surgery or whether it is post-operative period, while the patient is connected to monitor, in sinus rhythm, the change in the numbers, the heart rate showing will be very minimal. Like suppose the patient is having 80, it will show 78, 79, 80, 81, 82, like that, maybe 2 or 3 rates only. But when the patient is having AF, there will be wide variation in the rate when the monitor is showing. So whenever you get look at the monitor and the monitor is showing some 20, 120, 180, 80, 70, like the wide variation of the rate in the monitor, the patient will be in atrial fibrillation. That is one practical point.
Okay. So one more thing I would like to add, like you mentioned in the algorithm, the new onset or recent onset AF and chronic AF are to be dealt with in a totally different fashion. So we need to know whether the patient is already on AF. If it is a new onset of AF, we can deal with as a, like if it is a hemodynamically unstable or significant AF, we can proceed with cardioversion if required, or we can go for a pharmacological cardioversion. But chronic AF is a different entity.
Yeah.
Okay. You have to differentiate whether it is a paroxysmal or it is a persistent or paroxysmal. That you have to define it. So there is a clear-cut definition that paroxysmal and persistent are a irreversible AF. Then only you look at the diagnose the AF, and then accordingly medical cardioversion, or you go for a electrical cardioversion. So as far as the electrical cardioversion is concerned, you have to be a bit careful. The electrical cardioversion is almost always 99% of the cases it will be elective, so it may not be an acute one. So even if there is an acute one, we have to rule out. You have to do it for 24 hours. Strategy you have to make it. And 2 things we should keep it in mind. One thing is thromboprophylaxis has to be done for in these patients before cardioversion. Adequate thromboprophylaxis has to be done. So before cardioversion. And second thing is rule out LA clot always. Whenever there is a go for a cardioversion, rule out LA clot. Do an emergency echocardiogram, rule out, and then only go ahead with the cardioversions. I'm going to tell you the cardioversion details in that. So I think everybody knows about the rhythm control strategy of this algorithm. I'm going to put it in them. So for this, as far as this algorithm is concerned, you have to go ahead with this algorithm only. Okay. So this is the one which is, I think, as far as the echocardiographic findings, looking at the echocardiographic findings, you have to go ahead with the treatment of this bradycardia and this the heart rate. I think it is self-explanatory. I need not explain this, as Dr. Shifa has already explained regarding this. I hope, Shifa, shall I go ahead with?
Yeah. Okay, sir.
Drugs also there. I given metoprolol, esmolol, diltiazem, everything is there. So I given the dosage also is given. So you have to go ahead with the one. This is the one which I was telling about anticoagulation for cardioversions. Heparin to all the patients before every cardioversion should be given. Definitely less than 48 hours and more than 48 hours. The atrial fibrillation, it is less than 48 hours or more than 40 hours. So if it is less than 40 hours, you can go ahead with the cardioversion. If it is more than 48 hours, first and foremost thing is go for cardioversion, anticoagulation for 3 weeks and then attempt. Or else, if it is emergency, as I said earlier, go for a echo and then rule out the thrombus and then go for a cardioversion. I think this is self-explanatory, and anticoagulation should be continued 3 weeks earlier and 3 weeks after the cardioversion. I think he'll agree with the Shifa is going to agree with this statement.
Yes, sir. Even if we converted the atrial fibrillation to sinus rhythm, the atrial contract mechanical activity will come later only. So we have to continue the anticoagulation.
Okay. So what is meant by? So can anybody tell me what is meant by defibrillation? What is meant by cardioversion? Or what is meant by AED? It is very, very important as far as the postgraduate is concerned. Can anybody differentiate what is the defibrillation, AED, and then the cardioversion? It is very, very important for as far as the postgraduate is concerned.
Hello, sir.
Yeah.
Sir, a defibrillator is a capacitor, sir. Hello, sir. A defibrillator is a capacitor which delivers a pulse of current, sir. And defibrillator will be given by a trained health worker, sir.
Okay.
And it is asynchronous.
So defibrillation
sir. We not synchronize it.
going to stimulate. defibrillation, nothing but you are going to give electrical current, electrical shock, electrical impulses to the cardiac muscle to get a coordinated electric activity so that the patient will going to have an adequate cardiac output. This is the definition of defibrillation. Okay. So defibrillator is nothing but is a capacitor which on charges, it stores energy and then when you are use it, it will give energy in a pulse duration. So typical pulse duration is about 0.3 milliseconds. So with these milliseconds, it will going to give electrical shock to the heart muscle to get the electrical coordinated electrical activity to get an adequate cardiac output. Okay, this is defibrillation. What are the indications for defibrillations? What are the indications for defibrillations?
So indications are pulseless electrical activity, asystole, and BF.
So asystole is going to be used.
No, asystole, sir. Pulseless electrical activity and ventricular fibrillation.
I think everybody should be very clear. There should be a set of shockable rhythms and non-shockable rhythm. PEA and asystole are non-shockable rhythms. CPR and epinephrine are the answers. Pulseless VT and ventricular fibrillation are shockable rhythms. Okay, pulseless VT and ventricular fibrillation.
That's what I wanted, Shanish. That's everybody want to know this because wherever I go for exams, it is the same answer I'm getting it. So that's why everyone look at the algorithms. Pulseless selectivity and asystole go for adrenaline, not the S1 defibrillation. Ventricular fibrillation, go for defibrillation. That is the one. Okay. The indications for ventricular fibrillation is the defibrillation answer is directly. Okay. That's the concept of changing from AB to CAB. So 95% of the patients arrested in ventricular fibrillation. So they advocated in 2010 guidelines, the emergency cardiovascular care and ASA, they together, they are updating the guidelines every 5 years once. So during the 2010 guidelines, they entirely changed the scenario, ABC to CAB. This is the concept because 95% of the patient will arrested in ventricular fibrillation. So you should not waste time in ventilating the patients, arranging for the airway equipments, looking at the airway. So the precious time will be lost. So they changed the concept of ABC to CAB. That is the one. And second thing is, what about the AED? What is the difference between AED and defibrillations, Disha?
Sir, AED is an automated external defibrillator, sir. And this is usually available in the places where there are a lot of crowding, sir, like in...
what is the between conventional defibrillation and AED? What are the conventional differences?
So AED...
It is AED is nothing but it is a computerized
microprocessor, sir, based on...
Yeah.
Sir, it is a... Hello, sir.
Yeah.
AED is an automated external defibrillator. It consists of a microprocessor.
Audio is clear?
Yeah, it's okay. It's okay. It's okay.
Okay.
Yeah.
Sir, this AED delivers a predetermined current pulse duration, sir. So this does not require a trained health worker, whereas in defibrillator, we require a trained health worker, and we need to decide the amount of pulse to be given to the patient. In AED, it analyzes the rhythm and it prompts the user whether to give the shock or not. Whereas in defibrillation, we need to see the ECG and decide whether we can whether it is a shockable rhythm or a non-shockable rhythm.
Yes, very good. Okay, so main difference between defibrillation and AED is the defibrillation. We will go to select the energy, and you will go to put the pedals, and you will go to assess the rhythm, and then go into fire. Okay, you will go to give a shock. In AED is nothing but it is a microprocess based, and it is the rhythms is fixed, the current is fixed, and it will go to analyze the rhythm, and they'll going to prompt you whether it is a audio or it is a visual prompt. You'll going to prompt you whether to shock or not to shock. Okay, this is especially important in PAD programs. What is meant by PAD program? It is a public access defibrillation programs. Nowadays, it is 2015 guidelines. They're going to advocate. They're going to keep all AEDs. It can be used by a lay person. It is incorporated in all stadiums, all cinema halls, all the airport, and in bus stations and all railway stations. Everywhere they're going to incorporate. They're going to write the name of the person. They're going to write the mobile number of the person is there. Suddenly you can able to take it, call that person, you will going to prompt you what has to be done. This is nothing but public access defibrillation program, PAD program. It is advocated from 2015 guidelines onwards. Okay, everybody should know that. What do you mean by cardioversion? Tell me, can anybody tell me what do you mean by cardioversion?
So when the shock is synchronized with the R wave, it is called cardioversion.
Defibrillation and cardioversion, you will go both defibrillation and AED will going to have a asynchronized cardioversion. Okay, asynchronized shock will be given. Here it will going to give a synchronized shock. So one is synchronized shock. Second thing is, what is the second prerequisite?
Sir, here in the ECG, we should have P wave, QRS, and P wave, sir.
Yeah, so to cardiovert, you should have a definite PQ RST wave should be there to go for a cardioversion. Okay, so to cardiovert a patients, you should have a ECG, and ECG should have a definite identifiable PQ RST wave should be there. Okay, that is a prerequisite. Then, so you have to synchronize with the summit of the R wave. The third one is you have to synchronize with the summit of the R wave. So what is meant by a vulnerable period? Yeah, can you explain what is meant by a vulnerable period?
Sir,
You have to avoid the vulnerable period. What can you explain?
Sir, during vulnerable period, that is when we deliver during the downstroke of R wave or the P wave.
So you have to synchronize with the summit of the R wave that is there.
Hello.
Okay. When you do a cardioversion,
excuse me, sir.
Example, what are the indications for cardioversion? Yeah.
Manjunath sir, excuse me.
Yeah.
I think that Dr. Shifas wants to leave now because he has got a call from the hospital for consultation.
Okay.
Thank you, Shifas, for joining us. We enjoy having the cardiologist perspective. We would really like to have you for more CVS oriented or cardiology related topics in further sessions in Webinar Campus as well. Thank you very much for joining.
Okay, thank you. All the best for the pages. Yeah.
Thank you very much. Manjunath sir, you can continue.
I got only 2 or 3 slides. Sanish, I got only 2 or 3 days. I'll finish it off. Only 2 or 3 slides are there, Sanish. Okay. This cardioversion, I will only explain because it's audio is problematic. So this cardioversion we have to use. Only thing is synchronized current will be used, and you have to synchronize with the summit of the R wave. The vulnerable period is the one which is in the absolute relative refractory period from the downslope of the R wave up to the T wave. So downslope of the R wave up to the T wave is called relative refractory period. You have to avoid firing in this vulnerable period. If you fire in the downslope of the R wave on the T wave, you are going to end up with ventricular fibrillation. That what the Shifas was telling, this is nothing but. So if you do it on the summit, if you don't synchronize properly, and if your shock falls on the downslope of the R wave under the T wave, so then you will going to have ventricular, life-threatening ventricular fibrillation you're going to induce. Instead of reverting back the rhythm, you're going to induce ventricular fibrillation. This is nothing but RNT phenomenon. So you have to avoid firing on the vulnerable period. This is nothing but RNT phenomenon, and you have to concentrate on cardioversions. What are the indications for cardioversions usually, Shilpa? Where exactly you are going to do it? Which are the rhythms we are going to do? So atrial fibrillation, atrial flutter, we are going to do regularly, right? Atrial fibrillation. What are the difference between this? What are the current used? How will you going to do that? What is the current used in this defibrillation, and what is the current used in atrial fibrillation, cardioversion? Hello? Yeah, the current used in cardioversion is comparatively less in compared to defibrillation. So defibrillation we have got a monophasic and we have got a biphasic. So monophasic defibrillators, monophasic defibrillator. So I will go to explain. Forget about that. Okay. So monophasic defibrillation we have got current. So monophasic defibrillation we have got. So monophasic defibrillation we have got the currents from. So okay, explaining. Hello. Yeah, explain. Hello, explain.
Hello, sir.
Hello, explain. Explain. Explain.
Sir, in monophasic. Hello, sir.
Hello.
In monophasic current, we start at 100 joules. Then we increase it to 200 joules.
Okay.
Then to 360. Next,
So current strength will be monophasic will be from 100 to 360 joules. Okay, you have got a strength. You can select from 100, 200, 360 joules will be there in the monophasic. So in the biphasic, we have got up to 200. Recently, of late, there are some biphasic defibrillator, even up to 300, 360 joules are there, but it's not recommended. So there is no clear-cut recommendations how to use, what are the recommended sequence of the cardioversion. There is no clear-cut recommendation as far as the sequence of shock is concerned. So for monophasic, to defibrillation should be effective. So there are two things are very, very important. The current you choose and the waveform of this current, both are very important as far as the efficiency of defibrillation is concerned. So how will you go ahead with Nisha? Can you able to explain? Sanish, if it is a problematic cardio, I'll go to explain it. Okay.
Yeah.
Sanish?
Go ahead, sir.
Yeah, okay. So only thing is two things are there. Okay. So you have to select the current and you have to choose the waveform also. So monophasic is that there is a damped sinusoidal waveform are there. These two things are very, very important. So and biphasic current, it uses a less current compared to monophasic, and it covers in both the directions. And the current efficiency is very good, and the defibrillation efficacy is very good in basic, and there is no myocardial injury after the defibrillation. So you can use a less current. So there is no post myocardial injury will be less. And you are going to have a uniform, very good electrical shock will shock will be there, and uses very less current comparatively to monophasic. Now monophasic is preferred compared to biphasic is preferred compared to monophasic, I think. So now from 100 you can choose from 100 up to 200, and there is no recommended sequence. The recommended sequence only for monophasic. Monophasic, what we'll do is there are 6. Actually, the recommended sequence of shock is there are 6 shocks should be given for that. The first shock will be 100, and then choose the 200 shock, and then 360 joules. 100, next is 200, next is 360. So then the subsequent triplets of 360 has to be given for. So given the shock should be given. This is the recommended sequence as far as the monophasic defibrillation is concerned. As far as the biphasic is concerned, so the 360 is equal to 200 joules. Okay, what I'm saying, I think I'm correct. I think, Sanish, I'm correct. Yes, I think so. Yes, yeah, for 360 joules, 200 joules specific is definitely okay. So for that, the recommended sequence will be 100, then 200 you can use it, and after that 200 once, 200 twice, and 203. 3 places has to be given for that. Okay, but as far as the defibrillation is concerned, there is no clear-cut recommendation whichever is in the okay, there is no clear-cut recommendation for that. Okay.
We will go ahead.
Any queries
possible for defibrillation with that machine.
Okay. So I think everybody understood what is meant by defibrillation, what is meant by cardioversion, what is meant by AED. I hope I am clear regarding this. Okay, we'll go on to some scenarios. We'll finish up. So now for the first scenario, can anybody for the first scenario? Nisha?
The first one, sir.
Yeah. What about the first scenario?
Sir, in this, the heart rate is around 56 beats per minute, sir.
Okay.
And the rhythm is irregular, sir.
Okay. So next year only.
P1 is not related to QRS complex, sir.
Okay.
And this could be mostly inferior wall MI with high degree AV block.
Okay, let's read out now. So now read out, what is this one? Can you read it now? Interpretation. Heart rate is?
Sir. Here the heart rate is 56 beats per minute.
Okay.
As per ventricle, and for AT it is 112 beats per minute, sir.
Okay.
The rhythm is irregular. The voltage is normal. Axis is left. The position is horizontal, and there's no rotation, sir. P waves are not related to QRS complex. Coming to PR interval, there's no PR interval, sir.
Can you read it now? Can you read it now? Can you read? Sorry, can you read now? Now read it.
Sir. And coming to QRS complex is not wide. QRS duration is 0.04 seconds, sir. Coming to ST segment, there's elevation in lead 2, 3, and AVF, sir, which indicates inferior wall. And there's depression in lead 1, AVL, V5, and V6, sir. And coming to T wave, there's biphasic T wave in lead 2, 3, and AVF, and flat V6, sir. And Q interval is 0.36 seconds, and there's absence of U waves.
Okay.
So this is AV blocking myocardial infarction.
One question or high degree AV block, as I said, there is a concept of high degree AV block. So now what is the second scenario? Second scenario. Hello, Isha? Yeah.
The PR is pronounced, and QRS complexes is normal. ST segment is also normal, sir. And U waves are absent, sir. So here is hello, sir.
Oh, yeah, tell me.
Sir,
what is the interpretation? Will you interpret?
So it's a multifocal ventricular extrasystoles with left axis deviation.
Okay. How will you say it is a multifocal ventricular extrasystoles? What are the features? What is the multifocal?
Sir,
what is the rate? What is the rhythm? What is the rate? What is the rate? What is the rate? Heart rate here?
75 beats per minute.
Can you able to? Okay. It's approximately it's about 75 per minute. Okay. What is the voltage complex? What is the voltage? Is it a high voltage or a low voltage? Okay. What is the axis? Can you able to see the lead 1 and AVF? What is the axis? What is the R wave in lead 1? What is the R wave in lead 1? Yeah, just yeah. Lead 1 and AVF.
So this is left axis. R wave in E1 is positive, and in AVF it is negative, sir. So it comes to be axis deviation.
What is the P wave?
So P wave is present. It is upright, sir.
Okay. P wave is
normal, sir. Upright, sir.
What about the PR interval? Roughly. So PR interval.
PR interval is normal, sir.
Huh?
Hello, sir. So PR interval is prolonged.
What is the QR complex? The ST segment, T wave. Okay. So what is the how will you say it is a multifocal ventricular extrasystoles?
Because
what is the morphology?
White QRS complex, absent TV, and there is a compensated pause, sir.
What is the lead 6? What is the lead 6? What is the lead 6? Lead 6. What happened to the lead 6? So lead 6, what will going to happen? Lead 6 here. Okay. The second and third bit are multifocal extrasystoles. Multifocal extrasystoles.
Yes.
And V6 and 2 in yeah.
So the morphology that it is called excess because the morphology is
irritable ventricular muscle. So indicates irritable ventricular muscle with some heart disease. Okay.
Yes.
Okay. If it is more than 5, it needs treatment. So this interpretation is written here. So you can go through that. Once again, read it. Read the interpretation.
Yes.
So you have to rate, rhythm, voltage, axis, PR interval, QRS complex, everything should go, and then we go for multiple extrasystoles. So what about this? No, everybody should, at least somebody should make an attempt to read this. This ECG shows, I think, ventricular extrasystole with a bigeminy. Two are there. Okay, so first we'll go. What about this?
So here the rate is around 88 beats per minute, sir. The rhythm is irregular. Here the axis is normal, sir.
Okay.
And the PR interval is prolonged, and QRS complex is normal, sir.
Okay. What is the so what is the diagnosis of this?
So it is a ventricular premature.
Ventricular extrasystoles. Okay. That if you diagnose, that is more than enough for that. So what is this ECG? Can anybody comment on this ECG? Any comment on this ECG?
Sir, this is right bundle branch block, sir. Complete right bundle branch block.
So look at the V1 and V2. Look at the chest leads. V1 and V2, V3. Look at the chest leads. What happened to the V1 and V2? And is V1 and V2, V5, V6, V7. Look at the chest leads. V1, V2, V3. First and foremost thing is. So we have right bundle branch, features of right bundle branch back there. And the second thing is, so what are the inferior wall? Look at the inferior wall, son.
Inferior wall and lateral wall infarction, sir.
Yeah. Okay. So you have got inferior wall infarction ischemia, inferior wall, right? RBBB with inferior wall infarction. I think right. Okay. What about this ECG? Now, can anybody tell me what is this ECG? Sanish, are you getting any answers? Sanish, can you answer? Are you getting answers?
No, in the chat, nobody is answering. I think the picture is not very clear, I think. Maybe to know the RR interval and all.
Okay.
Yeah. Okay. Somebody answered.
At least this, somebody should answer this. Somebody should answer this.
Yeah.
Monomorphic VT, sir.
VT.
Okay. This is either you can do things with ventricular tachycardia or supraventricular tachycardia. So both you can diagnose it. It is a ventricular tachycardia or supraventricular tachycardia. You can diagnose it. If you look at this, so it should not miss. Especially this ventricular tachycardia should not miss. Okay. So what about this? What about this?
Sir, this shows right axis deviation and sinus
Tell me
tachycardia.
the diagnosis. Tell me the diagnosis. That is more than enough. These are the so with the diagnosis. Tell me the diagnosis. Huh?
Sinus tachycardia, sir.
Maybe it may be bit difficult for you people to diagnose it. Okay.
So there are T wave inversion also.
So you have got a Q wave here, shallow T wave. So this is, and this is some amount of transient RBBB, little bit RBBB is there. Very difficult to diagnose it. Okay. And ST elevation and T wave inversion in V4 and V4 to V6. Okay. And you have to go to diagnose for axis also. This is the classical picture of pulmonary embolism. I think yes. Yes. Sorry. Sinus tachycardia. Okay, we'll go ahead with this last one. Okay, this is the one. Yeah. Can you interpret this one? Anybody?
Ventricular hypertrophy, sir. Because in S wave in V1 and R wave in V6, it comes with 38 mm, sir.
So what is this? So is it a full? It's called polymorphic. So it is the look by looking at it only, it is not uniform. So different shapes are there. Can you able to diagnose it? If anybody diagnose it, is definitely good. Anybody in the audience?
Yeah, in the chat they're writing Tosadis.
Ventricular
polymorphic.
Yes, very good. It's a ventricular tachycardia with the Torsades points. I'm not getting that. It's okay. So it's a ventricular tachycardia with the Torsades points. So what about this? Anybody?
Sorry, your slide has not changed. Yeah, okay.
I changed that.
Yeah,
I changed it.
Ventricular fibrillation, sir.
Yeah, yes. What is the treatment of ventricular fibrillation? No. No, just recently I explained in detail.
Hello, sir.
Okay.
Ventricular defibrillation, sir.
Okay, defibrillation. Okay. Okay, to summarize, I think it's not there. No, yeah. Okay. Thank you, Sanish.
Okay, I think some of the ECGs you have shown are prototype ECGs. Like you should not miss out on identifying VF, especially if you are working in an acute medicine specialty like intensive care or anesthesia. So that is very important. The diagnosis should be spot on, and you should be spot on getting the defibrillator mobilized, get the crash cart in, go for defibrillation at the earliest. The more the time patient spends with the VF, his mortality chances will go up at least around 10% every minute. So earliest defibrillation, that time there is no scope of consultation, no point bringing in cardiologist. If there is a VF, there is no point checking the pulse also, it will be pulseless. And you arrange for defibrillation at the earliest. And one more thing I would like to point, like soon after defibrillation, there are two things American Heart Association stressed, like during the charging, you should continue effective CPR. Once the charging is done, charging of the defibrillator is done, you announce I clear, you clear, all clear, and then deliver the shock and then back it up with 5 cycles of CPR. Okay, don't look at the monitor immediately after defibrillating. You defibrillate, continue with CPR for another 2 minutes, then look at the monitor. If you find an organized rhythm, go for pulse check. Otherwise, you continue with the next cycle of defibrillation and as per ACLS protocol. The things should be clear. You should not wait for somebody else's input to continue the management, because every minute counts at that time. I think we have had an exhaustive discussion. ECG is not an easy topic, I know, but I tried to cover all the ECG topics. I think Manjunath sir has given all the ECGs which can be asked during your Viva for your exams. And actually, I was listening to these questions. Like, it's a very good opportunity for the residents to get the questions from the examiners. Okay, these questions should have the correct answer. You should not mess around with the answers. I think we have given the answers also for most of the questions. Okay, and sir, if you don't mind, I can circulate this presentation as a PDF into our Telegram group, because from the feedback, I understand that most of the people joined this program through our communication, through our Telegram groups, where we regularly give pre-test questions and this teaching materials. So we enjoyed the discussion. I think Dr. Shifas also tried to bring in a systematic approach to the ECG, and that part that is one aspect we'll be regularly missing in our academics, how a different specialty person thinks about ECG. ECG is definitely a cardiologist area, but definitely while working in acute medicine specialty like anesthesia and critical care or even emergency medicine, we should have a reasonable capability while interpreting ECG. Otherwise, for every ECG, you should be asking for a cardiologist to come in. So this has got practical implications.
So yes, so one more, Sanish. I think I'll request, I'll just tell advocate all the participate in this lecture. So everybody has got as their own phone, like they have got their phone. That's phone will be there. So in that phone, so please everybody go to your Play Store and go for this ACLS Rhythm Tour. That application will be there. So if you go for the ACLS Rhythm Tour, he has given beautifully explained everything. All the rhythms will be there. They have given a description. They have given the criteria, and they give the treatment also. Please, everybody, so go to the Play Store and look at the ACLS Rhythm Tour, and then go ahead with that. Every day, it will be in your hand. So it is definitely going to helpful during your intraoperative time. So you can able to identify the rhythms, and you can able to treat. So this is the one which is I think Play Store it's available. I definitely advocate everyone to go for this software, so you can able to download it and keep it in your mobile. And second thing is, thank you, Sanish.
Go ahead, sir. Yeah. Manjunath sir.
Thank you, Sanish.
Okay.
Yeah,
I
Tanish?
think further sessions will concentrate on subtopics of what we have discussed today. Maybe bradyarrhythmias for one session, tachyarrhythmias for one session, that cardioversion. We'll go in detail to the fundamentals. So this today we have given an overview. I know this has been exhaustive because ECG is not an easy topic, but perioperative handling of ECG is very important in our practice and for our exams. Manjunath sir, with your remarks, we'll conclude.
Thank you. Thank you, Dr. Sarish. And I think this is a beautiful session. And Dr. Shifas is explained the basics very well. And you are the way, this systematic way of reading the ECG. And I have given some scenarios, prototype. Sorry, that's especially pulmonary embolism, so ventricular fibrillation, tasodic points, and atrial fibrillation. These things are which you should not miss it, especially intraoperatively. So, and hemodynamics has to be monitored almost always whenever there is a arrhythmias comes. So most of the arrhythmias are benign most of the time. The normal patient also will get arrhythmias that will be benign. Only these arrhythmias will be important in a special scenario where the patient will be having pre-existing cardiovascular disease or a valvular heart disease patients, or if there is irritable myocardium, or if this a patient is having S1 is the thyroid disease, or some of the surgeries, the surgery, the phase of surgery is eye and intra is an abdominal because of the vagal stimulation. These are the situation where you will be very careful. Even a minor arrhythmia is very dangerous. Okay, that has to be taken care of. And before doing that, treating the patients, you look at the hemodynamics. If there is worsening hemodynamics, treat it promptly. That's all. So most of the arrhythmias which occurs normally, routinely, will be benign. So there is no need of treatment. That is my comment, last comment. Thank you, Sanish.
Okay, thank you very much, sir. And I take this opportunity to thank all the postgraduates and the participants who volunteered for interactive discussion. Thank you very much. We'll meet again with another topic in near future with another Webinar Campus episode. Thank you all for joining. Good night.
Thank you. Thank you, Sanish.
Thank you, sir.